Test. 1, 2. Okay. Welcome to Care of the Growing Family. Alright. Let's start some reading. I'm going to skip all that role the nurse stuff. That's all pretty general. And start with page 129 to 138, infertility. Infertility, contraception, and abortion. Okay, but this is just infertility. Incidence. Infertility is a serious medical concern that affects quality of life and is a problem for 10% to 15% of reproductive age couples. Infertility implies subfertility, a prolonged time to conceive, as opposed to sterility, or the inability to conceive. Normally, a fertile couple has approximately a 20% chance of conception in each ovulatory cycle. Primarily, infertility applies to a woman who has never been pregnant. Secondary infertility applies to a woman who has been pregnant in the past. The prevalence of infertility is relatively stable among the overall population. It increases with the age of the woman, particularly in those older than 40 years of age. Probable causes of infertility include the trend toward delaying pregnancy until later in life, when fertility decreases naturally and the prevalence of diseases such as endometriosis and ovulatory dysfunction increases. There are questions regarding whether there has been any increase in male infertility or whether it is more readily identified because of improvements in diagnosis. Diagnosis and treatment of infertility require considerable physical, emotional, and psychological and financial investment over an extended period. Men and women often perceive infertility differently. Women have more stress from tests and treatments, place greater importance on having children, are more accepting of indicated treatments, and want children more than men. In the United States, feelings connected with infertility are many and complex. The origins of some of these feelings are myths, superstitions, misinformation, or magical thinking. That's what I do. About the causes of infertility. Other feelings arise from the need to undergo many tests and examinations and from a perception of being different from others. The attitude, sensitivity, and caring nature of those who are involved in the assessment and treatment of infertility lay the foundation for the couple's ability to cope with the many tests and treatments they must undergo. Team members must respect individuals and couples' desires to choose in choosing to stop treatment and to select other alternatives such as remaining childless or adoption. Resolve, or www.resolve.com, is an organization that provides support, advocacy, and education about infertility for the infertility community as well as healthcare providers. Factors associated with infertility. Many factors, both male and female, contribute to normal fertility. A normally developed reproductive tract in both the male and female partners is essential. Normal functioning of an intact hypothalamic pituitary gonadal axis supports gametogenesis, or the formation of sperm and ova. The lifespans of the sperm and the ovum are short. Although sperm remains viable in the female's reproductive tract for 48 hours or more, probably only a few retain fertilization potential for more than 24 hours. Ova remain viable for about 24 hours, but the optimal time for fertilization may be no more than 1 to 2 hours. Thus, timing of intercourse becomes critical. The couple should be taught about the menstrual cycle and the way to detect ovulation. See Chapter 6. An alteration in one or more of these structures, functions, or processes results in some degree of impaired fertility. Causes of impaired fertility can lie with either the male or female. In general, about 20% of couples will have unexplained or idiopathic causes of infertility. Among the 80% of couples who have an identifiable cause of infertility, about 40% are related to factors in the female partner, 40% are related to factors in the male partner, and 20% are related to factors in both partners. Boxes 7.1 and 7.2 list factors affecting female and male infertility. Box 7.1, factors affecting female fertility. Ovarian factors, developmental anomalies, anovulation would be primary, and that's pituitary or hypothalamic hormone disorder, adrenal gland disorder, congenital adrenal hyperplasia, Anovulation, secondary, would be disruption of hypothalamic pituitary ovarian axis, amenorrhea after discontinuing oral contraceptive pills, and premature ovarian failure, increased prolactin levels. Okay, tubal peritoneal factors would be developmental anomalies, reduced tubal motility, inflammation within the tube, tubal adhesions, and endometriosis. Uterine factors would be developmental anomalies, endometrial and myometrial tumors, Asherman syndrome, or uterine adhesions or scar tissue on the uterus. Vaginal cervical factors would be vaginal cervical infections, cervical mucus inadequate, isoimmunization or development of sperm antibodies. Okay. And then other factors would be nutritional deficiencies, i.e. anemia, thyroid dysfunction, and idiopathic condition. So 7.2, box 7.2, factors affecting male fertility would be structural or hormonal disorders, undescended testes. So these are the structural or hormonal disorders would be undescended testes, hypospadias, I don't know what that is, varicocele, obstructive lesions of the epididymis and vas deferens, low testosterone levels, hypopituitarism, endocrine disorders, testicular damage caused by mumps, retrograde ejaculation, and then there's the substance abuse issues, which would be changes in sperm from cigarette smoking or use of heroin, marijuana, amyl nitrate, butyl nitrate, ethyl chloride, or methaqualone. Decrease in libido from use of heroin, methadone, selective serotonin reuptake inhibitors or barbiturates, and impotence from use of alcohol or antihypertensive medications. Other factors would be sexually transmitted infections, exposure to workplace hazards such as radiation or toxic substances, exposure of scrotum to high temperatures, nutritional deficiencies, anti-sperm antibodies, and idiopathic conditions. Okay. So, nursing care management. The nurse assists the assessment. See nursing process box. Some of the data needed to investigate impaired fertility are of a sensitive personal nature. Obtaining these data from or may be viewed as an invasion of privacy. The tests and examinations are occasionally painful and intrusive and can take the romance out of lovemaking. A high level of motivation is needed to endure this investigation. Because multiple factors involving both partners are common, the investigation of impaired fertility is conducted systematically and simultaneously for both male and female partners. Both partners must be interested in the solution to the problem. The medical investigation requires 3 to 4 months and considerable financial expense. Box 7.4. It causes emotional distress and strain on the couple's interpersonal relationship. Assessment of female infertility. Investigation of impaired fertility begins for the woman with a complete history and physical examination. A complete general physical examination is followed by a specific assessment of the reproductive tract. Laboratory data, including routine urine and blood tests, blood tests are collected. A woman may have an abnormal uterus and tubes, figure 7.1, as a result of an in utero exposure to dithystalbestrol, see box 5.2. A history of infection of the genitourinary system is noted. Bimanual examination of internal organs may reveal lack of mobility of the uterus or abdominal contours of the uterus and adnexa. Diagnostic testing. The basic infertility survey of the female involves evaluation of the cervix, uterus, tubes, and peritoneum. Detection of ovulation, hormone analysis, assessment of immunologic compatibility, and evaluation of psychogenic factors, table 7.1. Ultrasonography, timed during the luteal phase, endometrial biopsy, hysterosalpingography, X-ray examination of the uterine cavity and tubes after installation of radio-opaque contrast material through the cervix, is what a hysterosalpinography is, and laparoscopy to detect the possible treatment, such as endometriosis or adhesions in the peritoneal cavity, may be performed. The nurse can alleviate some of the anxiety associated with testing by explaining the timing and rationale for each test. Test findings favorable to fertility are summarized in box 7.5. Okay, so let's see. Nursing process. This is a box here for impaired fertility assessment. Obtain data relevant to fertility through interview and physical examination. Identify infertility as is primary or secondary. Note religious, cultural, and ethnic data because these may place restrictions on tests and treatments. Obtain results from diagnostic tests. See box 7.3. Her cultural awareness box. Okay, nursing diagnosis: disturbed body image or risk for situational low self-esteem related to impaired fertility. Decisional conflict related to therapies for impaired fertility, alternatives to therapy, e.g., child-free living or adoption. Sexual dysfunction related to loss of libido secondary to medically imposed restrictions, and social isolation related to impaired fertility, its investigation, and its management. Planning. Expected outcomes include that the woman family will do the following: verbalize understanding of the anatomy and physiology of the reproductive system, verbalize understanding of treatment for any abnormalities identified through various tests and examinations, and be able to make an informed decision about treatment, resolve guilt feelings, and not need to focus blame, conceive or failing to conceive, decide on an alternative acceptable to both of them, child-free living or adoption. Interventions. Teach, counsel, and reinforce information about tests and test results. Assist the couple to express and discuss feelings. Separate concepts of success and failure of treatment of infertility from personal success and failure. Recognize infertility as a loss and resolve these feelings even if treatment is successful. Okay, explore support systems of the couple. Persons available to assist, relationship to couple, ages, availability, available culture or religious support, refer for mental health counseling as necessary, and evaluation of the effectiveness of the care of the couple experiencing impaired fertility is based on the previously stated outcomes. Oh, man. This book is way harder to read than Iggy, but we'll keep plowing through here. Alright, I'll get a feel for it. Yeah. Cultural awareness. I'm not reading cultural awareness. I'm just not going to do it. Okay. Box 7.3. Religious considerations of infertility. Civil laws and religious prescriptions about sex must always be kept in mind by the healthcare provider. Conservative and Reformed Jewish couples are accepting of most infertility treatment. However, the Orthodox Jewish husband and wife may face problems in infertility investigation and management because of religious laws that govern marital relations. For example, according to Jewish law, the Orthodox couple may not engage in marital relations during menstruation and through the following 7 preparatory days. The wife then is immersed in a ritual bath, or a mikvah, before relations can resume. Fertility problems can arise when the woman has a short cycle, i.e. a cycle of 24 days or fewer, when ovulation would occur on day 10 or earlier. The Roman Catholic Church regards the embryo as a human being from the first moment of existence and regards as unacceptable technical procedures such as in vitro fertilization, IVF, therapeutic donor insemination, and freezing embryos. Other religious groups may have ethical concerns about infertility tests and treatments. For example, most Protestant denominations and Muslims usually support infertility management as long as IVF is done with the husband's sperm. There is no reduction of fetuses, and insemination is done with the husband's sperm. I just said that. These groups are less supportive of surrogacy and use of donor sperm and eggs. Christian Scientists do not permit surgical procedures or IVF, but do permit insemination with husband and donor sperm. Care providers should seek to understand the woman's spirituality and how it affects her perception of health care, especially in relation to infertility. Women may wish to seek infertility treatments but have questions about proposed diagnostic and therapeutic procedures. Because of religious prescriptions, these women are encouraged to consult their minister, rabbi, priest, or other spiritual leader for advice. Test, test. Testing 1, 2. Test, test. Okay. Okay, box 7-4, insurance coverage for infertility. As of October 2005, only 14 states had mandated some form of insurance coverage for infertility. These mandates included in vitro fertilization in some states, whereas others only covered some diagnostic tests. Some states require health maintenance organizations, or HMOs, to cover some costs, whereas in others, HMOs are exempt. Patients need information about what they can expect from their insurers. For questions about an individual state, call the state's insurance commissioner's office. The website for the American Society for Reproductive Medicine, www.asrm.org, has more complete information. Back to the text. Couples should be cautioned that everything can be normal and conception still may not occur. Unexplained infertility accounts for 20% of cases. Conversely, even poor test results do not mean that pregnancy will not occur. Assessment of male infertility. The systematic investigation of infertility in the male patient begins with a thorough history and physical examination. Assessment of the male patient proceeds in a manner similar to that of the female patient, starting with non-invasive tests. Semen analysis. The basic test for male infertility is semen analysis. A complete semen analysis, study of the effects of cervical mucus on sperm forward motility and survival, and evaluation of the sperm's ability to penetrate an ovum provide basic information. Sperm counts vary from day to day and depend on emotional and physical status and sexual activity. Therefore, a single analysis may be inconclusive. A minimum of 2 analyses must be performed several weeks apart to assess male fertility. Semen is collected by ejaculation into a clean container or a plastic sheath that does not contain a spermicidal agent. The semen is usually collected by masturbation following 2 to 5 days of abstinence from ejaculation. The semen is examined at the collection site or taken to the laboratory in a sealed container within 2 hours of ejaculation. Exposure to excessive heat or cold is avoided. Commonly accepted values for semen characteristics are given in box 7-6. If results are in the fertile range, no further sperm evaluation is necessary. If results are not within the range, the test is repeated. If subsequent results are still in the subfertile range, further evaluation is needed to identify the problem. Hormone analyses are done for testosterone, gonadotropin, follicle-stimulating hormone, or FSH, and luteinizing hormone, LH. The sperm penetration assay and other alternative tests can be used to evaluate the ability of sperm to penetrate an egg. Testicular biopsy may be warranted. Scrotal ultrasound is used to examine the testes for presence of varicocele and to identify abnormalities in the scrotum and spermatic cord. Transrectal ultrasound is used to evaluate the ejaculatory ducts, seminal vesicles, and vas deferens. Summary of findings favorable to fertility. 1. Follicular development, ovulation, and luteal development are supportive of pregnancy. A. Basal body temperature, presumptive evidence of ovulatory cycles, is biphasic with temperature evaluation that persists for 12 to 14 days before menstruation. Temperature elevation that persists for 12 to 14 days before menstruation. Cervical mucus characteristics change appropriately during phases of the menstrual cycle. Laparoscopic visualization of pelvic organs verifies follicular and luteal development. The luteal phase is supportive of pregnancy. Levels of plasma progesterone are adequate. Findings for endometrial biopsy samples are consistent with day of cycle. Cervical factors are receptive to sperm during expected time of ovulation. That would be A, cervical OS is open. Cervical mucus is clear, watery, abundant, and slippery, and demonstrates good spinbarkite and arborization or fern pattern. Okay. Cervical examination does not reveal lesions or infections. Postcoital test findings are satisfactory. Adequate number of live, motile, normal sperm present in cervical mucus. No immunity to sperm is demonstrated. 4. The uterus and uterine tubes are supportive of pregnancy. A, uterine and tubal pregnancies are documented by 1. Spillage of dye to the peritoneal cavity, and 2. Outlines of uterine and tubal cavities of adequate size and shape with no abnormalities. B. Laparoscopic examination verifies normal development of internal genitals and absence of adhesions, infections, endometriosis, and other lesions. 5. The male partner's reproductive structures are normal. A. There is no evidence of developmental abnormalities of penis, testicular atrophy, or varicose veins on the spermatic vein in the groin. There is no evidence of infection in prostate, seminal vesicles, and urethra. Testes are more than 4 centimeters in largest diameter. Okay. 6. Semen is supportive of pregnancy. A. Sperm number per milliliter are adequate in ejaculate. B. Most sperm show normal morphology. C. Most sperm are motile, forward moving. D. No autoimmunity exists. And E. Seminal fluid is normal. So back to the text. Assessment of okay, hold on first. Tests for impaired fertility. There'd be a hysterosalpingogram, and you would do that 7 to 10 days into the menstrual cycle. The rationale is late follicular, early proliferative phase will not disrupt a fertilized ovum, may open uterine tubes before time of ovulation. Postcoital test, 1 to 2 days before ovulation. Be ovulatory late proliferative phase. Look for normal motile sperm in cervical mucus. Then there's the sperm immobilization antigen antibody reaction test, and that's variable during ovulation. And that'd be an immunologic test to determine sperm and cervical mucus interaction. And then there's the assessment of cervical mucus. It's also variable during ovulation. The cervical mucus should have low viscosity and high spinbarkite, whatever that is. I think that's the fern pattern. Okay, and ultrasound diagnosis of follicular collapse would be during ovulation, and it would be a collapsed follicle is seen after ovulation. And there's the serum assay of plasma progesterone. That'd be 20 to 25 days of the menstrual cycle, and that would be mid-luteal, mid-secretory phase. That would be check adequacy of corpus luteal production of progesterone. Then there's the basal body temperature test, and that would be you'd have to chart the entire cycle, and it would be an elevation occurs in response to progesterone, documents ovulation. And then there would be the endometrial biopsy test, and that would be 21 to 27 days of the menstrual cycle, and that would be late luteal, late secretory phase, and that would be check endometrial response to progesterone and adequacy of luteal phase. And then there's the sperm penetration assay, and that would be after 2 days, but less than or equal to a week of abstinence. That would be evaluation of ability of sperm to penetrate an egg. Okay, back to the text. Assessment of the couple. Postcoital test. The postcoital test, PCT, is one method used to test for adequacy of coital technique. Cervical mucus, sperm, and degree of sperm penetration through cervical mucus. The test is performed within several hours after ejaculation of semen into the vagina. A specimen of cervical mucus is obtained from the cervical OS and examined under a microscope. The quality of mucus and the number of forward-moving sperm are noted. A PCT with good mucus and motile sperm is associated with fertility. Intercourse is synchronized with the expected time of ovulation as determined from evaluation of basal body temperature, or BBT. Cervical mucus changes and usual length of menstrual cycle or use of LH detection kit to determine LH surge. Intercourse should occur only in the absence of vaginal infection. Couples may experience some difficulty abstaining from intercourse for 2 to 4 days before expected ovulation and then having intercourse with ejaculation on schedule. Sex on demand may strain the couple's interpersonal relationship. A problem may arise if the expected day of ovulation occurs when facilities or the physician is unavailable, such as over a weekend or a holiday. Okay. Supposed to have sex at the hospital? That's crazy. Okay, so plan of care and implementation. Psychosocial. Infertility is recognized as a major life stressor that can affect self-esteem, relations with the spouse, family and friends, and careers. Psychologic responses to the diagnosis of infertility may tax a couple's capacity for giving and receiving physical and sexual closeness. The prescriptions and proscriptions for achieving conception may add tension to a couple's sexual functioning. Couples may report decreased desire for intercourse, orgasmic dysfunction, or mid-cycle erectile disorders. To be able to deal comfortably with the couple's sexuality, nurses must be comfortable with their own sexuality so that they can better help couples understand why the private act of lovemaking needs to be shared with the healthcare professionals. Nurses need to be up-to-date factual knowledge. Need up-to-date factual knowledge about human sexual practices and must be accepting of the preferences and activities of others without being judgmental. They must be skilled in interviewing and in therapeutic use of self, sensitive to therapeutic use of self, sensitive to the nonverbal cues of others, and knowledgeable regarding each couple's socio-cultural and religious beliefs. The woman or couple facing infertility exhibit behaviors of the grieving process that are associated with other types of loss. The loss of one's genetic continuity with the generations to come can lead to a loss of self-esteem, a sense of inadequacy as a woman or a man, or a loss of control over one's destiny and a reduced sense of self. Infertile individuals can have impaired self-concept and greater dissatisfaction with their marriages. Not all people have all the reactions described, nor can it be predicted how long any reaction will last for an individual. Semen analysis, box 7.6. Semen volume 2.5 milliliters, sperm concentration / density greater than or equal to 20 million per milliliter, sperm morphology greater than or equal to 30%, normal shaped heads greater than 14% motility, number of active cells as percentage of total number of cells should be greater than or equal to 50%. Quality of movement of sperm rated 0 to 4 should be greater than or equal to 2. And liquefaction, whatever that is, should be less than 20 minutes. Liquefaction. I don't know. Okay, so if the couple conceives, their concerns and problems concerning infertility may not be over. Many couples are overjoyed with the pregnancy, however some are not. Some couples rearrange their lives, sense of self, and personal goals based on accepting their infertile state. The couple may think that those who worked with them to identify and treat impaired fertility expect them to be happy with the pregnancy. They may be shocked to find that they feel resentment because the pregnancy, once a cherished dream, now necessitates another change in goals, aspirations, and identities. The normal ambivalence toward pregnancy may be perceived as reneging on their original choice to become parents. The couple might choose to abort the pregnancy at this time. Other couples worry about miscarriage. If the couple wishes to continue with the pregnancy, they will need the care other expectant couples need. If the couple does not conceive, they are assessed regarding their desire to be referred for help with adoption, therapeutic intrauterine insemination, other reproductive alternatives, or choosing a child-free state. The couple may find helpful a list of agencies, support groups, and other resources in their communities such as ASRM and Resolve. Non-medical. Simple changes in lifestyle may be effective in the treatment of subfertile men. Only water-soluble lubricants should be used during intercourse because many commonly used lubricants contain spermicides or have spermicidal properties. High scrotal temperatures may be caused by daily hot tub baths or saunas that keep the testes at temperatures too high for efficient spermatogenesis. These conditions lead to only lessened fertility and should not be used as a means of contraception. Treatment is available for women who have immunologic reactions to sperm. The use of condoms during genital intercourse for 6 to 12 months will reduce female antibody production in most women who have elevated anti-sperm antibody titers. After the serum reaction subsides, condoms are used at all times except at the expected time of ovulation. Approximately one-third of couples with this problem conceive by following this course of action. Change in nutrition and habits may increase fertility for both men and women. For example, a well-balanced diet, exercise, decreased alcohol intake, abstinence from smoking or abusing drugs, and stress management may be effective. Herbal alternative measures. Most herbal remedies may have not been proven clinically to promote fertility or to be safe in early pregnancy and should be taken by the women only as prescribed by a physician or nurse midwife who has expertise in herbology. Relaxation, osteopathy, stress management, e.g. aromatherapy and yoga, and nutritional and exercise counseling may have been reported to increase pregnancy rates in some women. Herbal remedies that promote fertility in general include red clover flowers, nettle leaves, dong kai, and false unicorn root. Vitamin E, calcium, and magnesium may promote fertility and conception. Vitamins E and C, glutathione, and coenzyme Q10 are antioxidants that have proven beneficial effects for male infertility. Herbs to avoid whilst trying to conceive include licorice root, yarrow, wormwood, ephedra, fennel, golden seal, lavender, juniper, flaxseed, pennyroyal, passionflower, wild cherry, cascara, sage, thyme, and periwinkle. Medical. Pharmacologic therapy for female infertility is often directed at treating ovulatory dysfunction by either stimulating or enhancing ovulation so that more oocytes, I don't know how to pronounce that. So that more oocytes mature. Whatever. These medications include clomiphene citrate, human menopause gonadotropin or HMG, FSH, recombinant FSH, or that's little r FSH, and human chorionic gonadotropin. Gonadotropin releasing hormone GnRH and agonists, progesterone and bromocriptine or parladel also are used. Bromocriptine is parladel. Okay. These medications are extremely potent and require daily monitoring with ovarian ultrasonography and monitoring of estradiol levels to prevent hyperstimulation. The incidence of multiple pregnancies with the use of these medications is greater than 25%. When failure to ovulate is caused by hypothalamic pituitary dysfunction or failure to respond to clomiphene or GnRH may be used. Thyroid stimulating hormone or synthroid is indicated if the woman has hypothyroidism. The woman with low estrogen levels may be a candidate for conjugated estrogens and medroxyprogesterone. A hypoestrogenic condition may result from a high stress level or from a decreased percentage of body fat as a result of an eating disorder, e.g. anorexia nervosa, or excessive exercise. Hydroxyprogesterone supplements with vaginal suppositories or intramuscular injection is used to treat luteal phase defects. The presence of adrenal hyperplasia, a glucocorticoid is taken orally. Treatment of endometriosis may include danazol, progesterone, combined oral contraceptives, or GnRH agonists. Infections are treated with appropriate antimicrobial formulations. Drug therapy may be indicated for male infertility. Problems with the thyroid or adrenal glands are corrected with appropriate medications. Infections are identified and treated with antimicrobials. FSH, HMG, and clomifene may be used to stimulate spermatogenesis in men with hypogonadism. The primary care provider is responsible for fully informing patients about the prescribed medications. However, the nurse must be ready to answer patients' questions and to confirm their understanding of the drug, its administration, potential side effects, and expected outcomes. Because information varies with each drug, the nurse must consult the medication package inserts, pharmacology references, the physician, and the pharmacist as necessary. Surgical. A number of surgical procedures can be used for the problems causing female infertility. Ovarian tumors must be excised. Whenever possible, functional ovarian tissue is left intact. Scar tissue adhesions caused by chronic infections may cover much or all of the ovary. These adhesions usually necessitate surgery to free and expose the ovary so that the ovulation can occur. Hysterosalpingography is useful for identification of tubal obstruction and also for the release of blockage, figure 7.2. During laparoscopy, delicate adhesions may be divided and removed, and endometrial implants may be destroyed by electrocoagulation or laser, figure 7.3. Laparotomy and even microsurgery may be required for extensive repair of the damaged tube. Prognosis depends on the degree to which tubal patency and function can be restored. Patency. Reconstructive surgery, e.g. the unification operation for bicornuate uterus, often improves a woman's ability to conceive and carry the fetus to term. What are we talking about? Reconstructive surgery, unification operation for bicornuate uterus. Okay. Often improves the woman's ability to conceive and carry the fetus to term. Surgical removal of tumors or fibroids involving the endometrium or uterus often improve the woman's chance of conceiving and maintaining the pregnancy to viability. Surgical treatment of uterine tumors or maldevelopment that results in successful pregnancy usually requires birth by cesarean surgery near-term gestation because the enlarging uterus may rupture as a result of weakness in the area of reconstructive surgery. Chronic inflammation and infection can be eliminated by radial chemocautery, or that's the destruction of tissue with chemicals, or thermocautery, that would be the destruction of tissue with heat, usually electrical, of the cervix. Cryosurgery, destruction of tissue, application of extreme cold using liquid nitrogen, or conization, that would be an excision of a cone-shaped piece of the tissue from the endocervix. When the cervix has been deeply cauterized or frozen, or when extensive conization has been performed, extreme limitations of mucus production by the cervix may result. Therefore, the absence of a mucus bridge from the vagina to the uterus can make sperm migration difficult or impossible. Therapeutic intrauterine insemination may be necessary to carry the sperm directly through the internal os of the cervix. Surgical procedures may also be used for problems causing male infertility. Surgical repair of varicocele has been relatively successful in increasing sperm count, but not fertility rates. Microsurgery to re-anastomose or restore tubal continuity, the sperm ducts after vasectomy can restore fertility. Okay. Reverse vasectomy. Okay, assisted reproductive therapies. Assisted reproductive therapies. Although there has been remarkable developments in reproductive medicine, assisted reproductive therapies, or ARTs, account for less than 1% of all U.S. births and less than 3% of infertility treatment. ARTs are associated with many ethical and legal issues. The lack of information or misleading information about success rates and the risks and benefits of treatment alternatives prevents couples from making informed decisions. Nurses can provide information so that the couples have an accurate understanding of their chances for a successful pregnancy and live birth. Nurses also can provide anticipatory guidance about the moral and ethical dilemmas regarding the use of ARTs. Some of the ARTs for treatment of infertility include in vitro fertilization, embryo transfer, or IVF or ET, and gamete intrafallopian transfer, or GIFT, figure 7.4. Zygote intrafallopian transfer, ZIFT, or ovum transfer, that would be oocyte donation. Embryo adoption, embryo hosting, and surrogate parenting, and therapeutic donor insemination, or TDI. Therapeutic donor insemination, whatever that is. Table 7.2 describes these procedures and the possible indications for ARTs. Other options include intracytoplasmic sperm injection, assisted hatching, and adoption. Legal tip. Cryopreservation of human embryos. Couples who have excess embryos frozen for later transfer must be fully informed before consenting to the procedure to make decisions regarding the disposal of embryos in the event of death, divorce, or the decision at a later time that the couple no longer wants the embryos. So, box 7.7, issues to be addressed by infertile couples before treatment: risks of multiple gestation, possible need for multifetal reduction, possible need for donor oocytes, sperm or embryos, or for gestational carrier, surrogate mother, whether to or how to disclose facts of conception to offspring, freezing embryos for later use, possible risks for long-term effects of medications and treatment on women, children, and families. Okay, complications. Other than the established risks associated with laparoscopy and general anesthesia, few risks are associated with IVF, ET, GIFT, and ZIFT. The more common transvaginal needle aspiration requires only local or intravenous analgesia. Congenital anomalies occur no more frequently than among naturally conceived embryos. Multiple gestations are more likely and are associated with increased risk for both the mother and fetuses. However, ectopic pregnancies do occur more often, and these carry a significant maternal risk. There is no increase in maternal or perinatal complications with TDI. Same frequencies of anomalies, about 5%, and obstetric complications between 5% and 10% that accompany natural insemination through sexual intercourse also apply to TDI. I forgot what's TDI again. Therapeutic donor insemination. Okay. Pre-implantation genetic diagnosis. Pre-implantation genetic diagnosis, PGD, is a form of early genetic testing designed to eliminate embryos with serious genetic diseases before implantation through one of the ARTs and to avoid future termination of pregnancy for genetic reasons. Micromanipulation allows removal of a single cell from a multicellular embryo for genetic study, i.e., embryo biopsy. PGD is used clinically in over 20 centers around the world. Couples must be counseled about their options and choices with the implications of their choices when genetic analysis is considered. For example, the transfer of only embryos that are free from abnormalities can increase the implantation rate and decrease the risk or the miscarriage rate, and may increase the likelihood of the birth of a healthy infant. I'm going to read Table 7.2. Assisted reproductive therapies. So there's in vitro fertilization transfer, IVF, ET. Definition: a woman's eggs are collected from her ovaries, fertilized in a laboratory with sperm, and transferred to her uterus after normal embryo development has occurred. Indications: tubal disease or blockage, severe male infertility, endometriosis, unexplained infertility, cervical factor, immunologic infertility. And then there's the gamete intrafallopian transfer, or the gift. And that's oocytes are retrieved from the ovary, placed in a catheter with washed motile sperm, and immediately transferred into the fimbriated end of the uterine tube. Fertilization occurs in the uterine tube. Okay, same as the IVF. Indications are same as the IVF ET, except there must be normal tubal anatomy, patency, and absence of previous tubal disease in at least one uterine tube. And there's the IVF ET and gift with donor sperm. This process is the same as described previously, except in cases where the husband's fertility is severely compromised and donor sperm can be used. If donor sperm are used, the wife must have indications for IVF and gift. Indications: severe male infertility, azoospermia, indications for IVF, ET, or gift. And then the procedure would be zygote intrafallopian transfer, or ZIFT. And this process is similar to IVFT or IVFET. After in vitro fertilization, the ova are placed in one uterine tube during the zygote stage, same as the gift. Okay, there's donor oocyte. That'd be eggs are donated by an IVF procedure, and the donated eggs are inseminated. The embryos are transferred into the recipient's uterus, which is hormonally prepared with estrogen / progesterone therapy. Indications would be early menopause, surgical removal of ovaries, congenital absence of ovaries, autosomal or sex-linked disorders, lack of fertilization in repeated IVF attempts because of subtle oocyte abnormalities or defects in oocyte-spermatoza interaction. Procedure would be donor embryo or embryo adoption, and that would be a donated embryo is transferred to the uterus of an infertile woman at the appropriate time, normal or induced, of the menstrual cycle. Infertility indications would be infertility not resolved by less aggressive forms of therapy, absence of ovaries, male partners azoospermic or severely compromised. And then there's a gestational carrier, embryo host, or surrogate mother. A couple undertakes an IVF cycle, and the embryo is transferred to another woman's uterus. The carrier, who has contracted with the couple to carry the baby to term. The carrier has no genetic investment in the child. Surrogate motherhood is a process by which a woman is inseminated with semen from the infertile woman's partner and then carries the baby until birth. Indications would be congenital absence or surgical removal of uterus, a reproductively impaired uterus, myomas, uterine adhesions or other congenital abnormalities, a medical condition that might be life-threatening during pregnancy, such as diabetes, immunologic problems, or severe heart, kidney, or liver disease. Or they're just really rich and they have other people have babies for them. I think that can happen. Okay. Therapeutic donor insemination, TDI. Donor sperm are used to inseminate the female partner. That'd be male partner is azoospermatic or has a very low sperm count, couple has genetic defect, male partner has anti-sperm antibodies. And there's intracytoplasmic sperm injection. That would be one sperm is selected to be injected directly into the egg to achieve fertilization. It is used with IVF. And that would be same as TDI for indications. Okay. Assisted hatching. That would be the zona pellucida is penetrated chemically or manually to create an opening for the dividing embryo to hatch and implant into the uterine wall. Indication would be recurrent miscarriages to improve implantation rate in women with previously unsuccessful IVF attempts, advanced age. Okay, we got through that. Now we're on to adoption. Couples who may choose to build their family by adopting children who are not their own biologically, with increased availability of birth control and abortion, and an increase in single mothers who choose to keep their babies. The availability of Caucasian infants for adoption is extremely limited. Minority infants, infants with special needs, older children, and foreign adoption are other options. Okay. Couples who decide to adopt a child have decided that being a parent is more important than the actual process of birthing the child. The birth process is very small aspect of having a baby and becoming a parent. So much emphasis is placed on being pregnant and having a child composed of one's own genetic makeup that the focus of the reason to have a child becomes cloudy. The question to be answered by couples who want to adopt is, do you want to give birth to a baby, or do you want to become a parent? Okay, on to pages 171 to 186, conception and fetal development. Oh, fun. All right. So, page 171 just starts off with, it's just a big, huge chart that basically shows the 38 weeks of pregnancy with different time frames when the fetus is highly sensitive to defects, when they're less sensitive, and kind of just the stages. Just kind of go through it real generally. The first 2 weeks is the period of dividing the zygote, implantation, and bilaminar embryo. The first week it divides, then it turns into the morula, or that little clump of cells. Then it's turns into the blastocyte, or the blastocyst, that is. Second week, it's an embryonic disc, and that's all it really says there. It says death of the embryo and spontaneous abortion are common in the first 2 weeks. Third week, then it goes 3 to 38. Week 3 to week 8 are the main embryonic period, and weeks 9 to 38 are the fetal period. Neural tubal defects, or NTDs, and mental retardation are the highly sensitive period for those is weeks 3 through 16, and then CNS defects would be weeks 32 through 38. TA, ASD, and VSD, not sure what those are, but that would be about 3.5 weeks to 7 weeks. And then the heart would be vulnerable between about 6.5 to 8 weeks. Amelia and meromelia would be to about 5 weeks, almost, a little more than almost 6 weeks. And then upper limbs would be big during the 5th to 8 weeks. Amelia and memoralia, again, like 3 to 6. And lower limbs would be like same as before, 6 to 8 or 9. Cleft lip, that would be 5 to 6 week, and upper lip would be 7 to 8 week. Low set, malformed ears and deafness, sensitive during about middle of the 4th week to the middle of the 9th week, and then just ears in general would be middle of the 9th week to about 32nd week. And then microphthalmia, cataracts, and glaucoma, that'd be sensitive, highly sensitive during 4th to 8th week, and just eyes in general are less sensitive period, but still forming from the 8th to the end. Enamel hypoplasia and staining, very sensitive during 6th to 8th week. And cleft palate, very sensitive from the 6th to the about 9th week. And masculinization or female genitalia happening 7 through 9-ish. Oh, TA is truncus arteriosus, ASD is atrial septal defect, and VSD is ventricle septal defect, so I'll have to do with the heart. Okay, so let's start up here with conception. Conception, cell division. Cells are reproduced by two different methods, mitosis and meiosis. In mitosis, the body cells replicate to yield two cells with the same genetic makeup as the parent cell. First, the cell makes a copy of its DNA, and then it divides. Each daughter cell receives one copy of the genetic material. Mitotic division facilitates growth and development of cell replacement. Meiosis, the process by which germ cells divide and decrease their chromosome number by half, produces gametes, eggs and sperm. Each homologous pair of chromosomes contains one chromosome received from the mother and one from the father. Thus, meiosis results in cells that contain one of each of the 23 pairs of chromosomes. Because these germ cells contain 23 single chromosomes, half of the genetic material of a normal somatic cell, they are called haploid. Because these germ cells contain 23 single chromosomes, half of the genetic material of a normal somatic cell, they are called haploid. Oh, okay. When the female gamete, or egg or ovum, and the male gamete, the spermosome, unite to form the zygote, the diploid number of human chromosomes, 46, or 23 pairs, is restored. The diploid. The process of DNA replication and cell division in meiosis allows different alleles, or genes, on corresponding loci that code for variations of the same trait for genes to be distributed at random by each parent and then rearranged on the paired chromosomes. The chromosomes then separate and proceed to different gametes. Because the two parents have genotypes derived from 4 different grandparents, many combinations of genes on each chromosome are possible. This random mixing of alleles accounts for the variation of traits seen in the offspring of the same two parents. Okay, gametogenesis. Oogenesis. The process of egg or ovum formation begins during fetal life of the female. All the cells that may undergo meiosis in a woman's lifetime are contained in her ovaries at birth. The majority of the estimated 2 million primary oocytes, the cells that undergo the first meiotic division, degenerate spontaneously. Only 400 to 500 ova will mature during the approximately 35 years of a woman's reproductive life. The primary oocytes begin the first meiotic division, i.e., they replicate their DNA. During fetal life, but remain suspended at this stage until puberty. Okay? Then, usually monthly, one primary oocyte matures and completes the first meiotic division, yielding 2 unequal cells, the secondary oocyte and a small polar body. Both contain 22 autosomes and 1 X sex chromosome. And at ovulation, the second meiotic division begins. However, the ovum does not complete the second meiotic division unless fertilization occurs. Okay. At fertilization, a second polar body and the zygote, the united egg and sperm, are produced. See figure 8.5. The three polar bodies degenerate. If fertilization does not occur, the ovum also degenerates. Okay. So when a male reaches puberty, his testes begin the process of spermatogenesis. The cells that undergo meiosis in the male are called spermatocytes. The primary spermatocyte, which undergoes the first meiotic division, contains the diploid number of chromosomes. The cell has already copied its DNA before division, thus 4 alleles for each gene are present. Because the copies are bound together, i.e. one allele plus its copy on each chromosome, the cell is still considered diploid. Okay. During the first meiotic division, 2 haploid secondary spermatocytes are formed. Each secondary spermatocyte contains 22 autosomes and 1 sex chromosome. One contains the X chromosome plus its copy, and the other the Y chromosome plus its copy. During the second meiotic division, the male produces 2 gametes with an X chromosome and 2 gametes with a Y chromosome, all of which will develop into viable sperm. Okay. Conception. Conception, defined as the union of a single egg and sperm, marks the beginning of a pregnancy. Conception occurs not as an isolated event, but as part of a sequential process. The sequential process includes gamete, egg, and sperm formation, ovulation, release of the egg, union of the gametes, which results in an embryo, and implantation in the uterus. Ovum. Meiosis occurs in the female in the ovarian follicles and produces an egg, or ovum. Each month, one ovum matures with a host of surrounding supportive cells. At ovulation, the ovum is released from the ruptured ovarian follicle. High estrogen levels increase the motility of the uterine tube so that the cilia are able to capture the ovum and propel it through the tube toward the uterine cavity. As ovum cannot move by itself. 2 protective layers surround the ovum, figure 8.6. The inner layer is a thick acellular layer called the zona pellicida. The outer layer, called the corona radiata, is composed of elongated cells. Ova are considered fertile for approximately 24 hours after ovulation. If unfertilized by a sperm, the ovum degenerates and is resorbed. Okay. Sperm. Ejaculation during sexual intercourse normally propels about a teaspoon of semen containing as many as 200 to 500 million sperm into the vagina. The sperm swim by means of the flagellar movement of their tails. Some sperm can reach the site of fertilization within 5 minutes, but average transit time is 4 to 6 hours. Sperm remain viable within the woman's reproductive system for an average of 2 to 3 days. Most sperm are lost in the vagina, within the cervical mucus, or in the endometrium, or they enter the tube that contains no ovum. Haha. Road less traveled. As sperm travel through the female reproductive tract, enzymes are produced to aid in their capacitation. Capacitation is a physiologic change that removes the protective coating from the heads of the sperm. Small perforations then form in the acrosome, a cap on the sperm, and allow enzymes, e.g. hyaluronidase, to escape. Okay, figure 8.6. These enzymes are necessary for the sperm to penetrate the protective layers of the ovum before fertilization. Okay. So 173 just has a bunch of charts, or not charts, but graphic stuff showing you how bunch of about the polar bodies and the secondary oocytes and the primary oocytes, and the mature ovum. So the primary oocytes have the diploid number, and the secondary oocytes have the haploid number. And there's polar bodies, and there's ova, and there's sperm, there's zygotes. After the sperm it goes in it comes the zygote. Yeah, and then down here there's the achromosal cap, which gets taken off, and there's the bunch of other crap. Okay, fertilization. Fertilization takes place in the ampulla, or the outer third of the uterine tube. When a sperm successfully penetrates the membrane surrounding the ovum, both sperm and ovum are enclosed within the membrane. Okay. And the membrane becomes impenetrable to other sperm. This process is termed the zona reaction. The second meiotic division of the secondary oocyte is then completed, and the ovum nucleus becomes the female pronucleus. The head of the sperm enlarges to become the male pronucleus, and the tail degenerates. The nuclei fuse, and the chromosomes combine, restoring the diploid number 46, figure 8-7. Okay, conception, the formation of the zygote, the first cell of the new individual, has been achieved. Meiotic cellular replication, called cleavage, begins as the zygote travels the length of the uterine tube into the uterus. This voyage takes 3 to 4 days. Because the fertilized egg divides rapidly with no increase in size, successively smaller cells, called blastomeres, are formed with each division. A 16-cell morula, a solid ball of cells, is produced within 3 days and is still surrounded by the protective zona pellucida. Figure 8-8. Further development occurs as the morula floats freely within the uterus. Fluid passes through the zona pellucida into the intracellular space between the blastomeres, separating them into 2 parts: the trophoblast, which gives rise to the placenta, and the embryoblast, which gives rise to the embryo. A cavity forms within the cell mass as the spaces come together, forming a structure called the blastocyst cavity. When the cavity becomes recognizable, the whole structure of the developing embryo is known as the blastocyst. Stem cells are derived from the inner cell mass of the blastocyst. Okay. The outer layer of cells surrounding the cavity is the trophoblast, which is the placenta. Implantation. The zona pellucida degenerates. The trophoblast cells displace endometrial cells at the implantation site, and the blastocyst embeds in the endometrium, usually in the anterior or posterior fundal region. Between 6 and 10 days after conception, the trophoblast secretes enzymes that enable it to burrow into the endometrium until the entire blastocyst is covered. This is known as implantation. Endometrial blood vessels erode, and some women have implantation bleeding, slight spotting and bleeding during the time of the first menstrual period. Chorionic villi, or finger-like projections, develop out of the trophoblast and extend into the blood-filled spaces of the endometrium. These villi are vascular processes that obtain oxygen and nutrients from the maternal bloodstream and dispose of carbon dioxide and waste products into the maternal blood. Awesome. After implantation, the endometrium is called the decidua. The portion directly under the blastocyst, where the chorionic villi tap into the maternal blood vessels, is the decidua bacillus. The portion covering the blastocyst is the decidua capsularis. Okay, and the portion lining the rest of the uterus is the decidua vera. Okay. Okay, the embryo and fetus. Pregnancy lasts approximately 10 lunar months, 9 calendar months, or 40 weeks, or 280 days. Length of pregnancy is compared from the first day of the last menstrual period, or the LMP, until the day of birth. However, conception occurs approximately 2 weeks after the first day of the LMP. Thus, the post-conception age of the fetus is 2 weeks less, for a total of 266 days, or 38 weeks. Post-conception age is used in the discussion of fetal development. Intrauterine development is divided into 3 stages: ovum or pre-embryonic, embryo and fetus. Intrauterine development is divided into 3 stages: ovum or pre-embryonic, embryo, and fetus. The stage of the ovum lasts from conception until day 14. This period covers cellular replication, blastocyst formation, initial development of the embryonic membranes, and the establishment of the primary germ layers. Primary germ layers. During the 3rd week after conception, the embryonic disc differentiates into 3 primary germ layers. There's the ectoderm, the mesoderm, and the endoderm, or entoderm. All tissues and organs of the embryo develop from these 3 layers. Okay, the ectoderm, the upper layer of the embryonic disc, gives rise to the epidermis, glands, anterior pituitary, cutaneous, and mammary, nails and hair, central and peripheral nervous systems, lens of the eye, tooth, enamel, and floor of the amniotic cavity. Okay. The mesoderm, the middle layer, develops into the bones, the teeth, the muscles, the skeletal, smooth, and cardiac muscles, dermis and connective tissue, cardiovascular system and spleen, and urogenital system. The endoderm, the lower layer, gives rise to the epithelium lining and respiratory and digestive tracts, including the oropharynx, liver, and pancreas, urethral bladder, and vagina. The endoderm forms the roof of the yolk sac. Okay. Development of the embryo. The stage of the embryo lasts from 15 days until approximately 8 weeks after conception. When the embryo measures approximately 3 centimeters from crown to rump, the embryonic stage is the most critical. The stage of the embryo lasts from day 15 until approximately 8 weeks after conception, when the embryo measures approximately 3 centimeters from crown to rump. The embryonic stage is the most critical time in the development of the organ systems and the main external features. Developing areas with rapid cell division are the most vulnerable to malformation caused by environmental teratogens. At the end of the 8th week, all organ systems and external structures are present, and the embryo is unmistakably human. See Figure 8.4 and visible embryo blah 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 for patera blah blah blah. Membranes. At the time of implantation, two fetal membranes that will surround the developing embryo begin to form. The chorion develops from the trophoblast and contains the chorionic villi on its surface. The villi burrow into the decidua bacillus and increase in size and complexity as the vascular processes develop into the placenta. The chorion becomes the covering of the fetal side of the placenta. It contains the major umbilical blood vessels that branch out over the surface of the placenta as the embryo grows. As the embryo grows, the decidua capsularis stretches, the chorionic villi on this side atrophy and degenerate, leaving a smooth chorionic membrane. The inner cell membrane, the amnion, develops from the interior cells of the blastocyte. The inner cell membrane, the amnion, develops from the interior cells of the blastocyte. The cavity that develops between this inner cell mass and the outer layer of cells of the trophoblast is the amniotic cavity. As it grows larger, the amnion forms on the side opposite the developing blastocyst. The developing embryo draws the amnion around itself to form a fluid-filled sac. The amnion becomes the covering of the umbilical cord and covers the chorion on the fetal surface of the placenta. Okay. As the embryo grows larger, the amnion enlarges to accommodate the embryo/fetus and the surrounding amniotic fluid. The amnion eventually comes in contact with the chorion surrounding the fetus. Okay. Amniotic fluid. At first, the amniotic cavity derives its fluid by diffusion from the maternal blood. The amount of fluid increases weekly in 800 to 1200 milliliters of transparent liquid is normally present at term. The volume of amniotic fluid changes constantly. The fetus swallows fluid, and fluid flows into and out of the fetal lungs. The fetus urinates into the fluid, greatly increasing its volume. The amniotic fluid serves many functions for the embryo fetus. Amniotic fluid helps maintain a constant body temperature. It serves as a source of oral fluid and as a repository for waste. It cushions the fetus from trauma by blunting and dispersing outside forces. It allows freedom of movement for musculoskeletal development. The fluid keeps the embryo from tangling with the membranes, facilitating symmetric growth of the fetus. If the embryo does not become tangled with the membranes, amputations of extremities or other deformities can occur from constricting amniotic bands. The volume of amniotic fluid is an important factor in assessing fetal well-being. Having less than 300 milliliters of amniotic fluid, or oligohydramnios, is associated with fetal renal abnormalities. Having more than 2 liters of amniotic fluid, or hydramnios, is associated with gastrointestinal and other malformations. Amniotic fluid contains albumin, urea, uric acid, creatinine, lecithin, sphingomyelin, bilirubin, fructose, fat, leukocytes, protein, epithelial cells, enzymes, and lanugo hair. Okay, contains lanugo hair. It's weird. Study of fetal cells in amniotic fluid through amniocentesis yields much information about the fetus. Genetic studies or karyotyping provide knowledge about the sex and the number and structure of chromosomes. Other studies, such as lecithin slash sphingomyelin or L/S ratio, determine the health or maturity of the fetus. See Chapter 9. Okay, pick up the pace here. Yolk sac. At the same time, the amniotic cavity and amnion are forming. Other blastocyst cavities forms on the other side of the developing embryonic disc. This cavity becomes surrounded by a membrane forming the yolk sac. Okay, yolk sac. The yolk sac aids in transferring maternal nutrients and oxygen, which have diffused through the chorion to the embryo. Blood vessels form to aid transport. Blood cells and plasma are manufactured in the yolk sac during the second and third weeks, while uteroplacental circulation is being established and forming primitive blood cells into hematopoietic activity begins. At the end of the third week, the primitive heart begins to beat and circulate the blood through the embryo, connecting stalk, chorion, and yolk sac. The folding in of the embryo during the fourth week results in incorporation of part of the yolk sac into the body of the embryo as the primitive digestive system. Primordial germ cells arise in the yolk sac and move into the embryo. The shrinking remains of the yolk sac degenerate, and by the fifth or sixth week, the remnant has separated from the embryo. Weird. Okay, umbilical cord. By day 14 after conception, the embryonic disc or amniotic sac and yolk sac are attached to the chorionic villi by the connecting stalk. During the third week, the blood vessels develop to supply the embryo with maternal nutrients and oxygen. During the fifth week, the embryo is curved inward on itself from both ends, bringing the connecting stalk to the ventral side of the embryo. The connecting stalk becomes compressed from both sides of the amnion and forms the narrower umbilical cord. Two arteries carry blood from the embryo to the chorionic villi, and one vein returns blood to the embryo. Approximately 1% of umbilical cords contain only two vessels, one artery and one vein. This occurrence is sometimes associated with congenital malformations. Okay. The cord rapidly increases in length. At term, the cord is 2 centimeters in diameter and ranges from 30 to 90 centimeters in length, with an average of 55 centimeters. If it twists spirally on itself and loops around the embryo fetus, a true knot is rare, but false knots occur as folds or kinks in the cord and may jeopardize circulation to the fetus. Connective tissue called Wharton's jelly prevents compression of the blood vessels and ensures continued nourishment of the embryo fetus. Compression can occur if the cord lies between the fetal head and the pelvis or is twisted around the fetal body. When the cord is wrapped around the fetal neck, it is called a nuchal cord. Because the placenta develops from the chorionic villi, the umbilical cord is usually located centrally. The blood vessels are arrayed out from the center to all parts of the placenta. Okay, a peripheral location is less common and is known as a battledore placenta. Okay. Placenta structure. The placenta begins to form its implantation. begins to form at implantation. During the third week after conception, the trophoblast cells of the chorionic villi continue to invade the decidua bacillus. As the uterine capillaries are tapped, the endometrial spiral arteries fill with maternal blood. The chorionic villi grow into the spaces with two layers of cells, the outer syncytium and the inner cytotrophoblast. A third layer develops into anchoring septa, dividing the projecting decidua into separate areas called cotyledones. In each of the 15 to 20 cotyledones, the chorionic villi branch out and a complex system of fetal blood vessels forms. Each cotyledone is a functional unit. The whole structure is the placenta. The maternal placental embryonic circulation is in place by day 17 when the embryonic heart starts beating. By the end of the third week, the embryonic blood is circulating between the embryo and the chorionic villi. In the intervillous spaces, the maternal blood supplies oxygen and nutrients to the embryonic capillaries in the villa. Waste products and carbon dioxide diffuse into the maternal blood. The placenta functions as a means of the metabolic exchange. Exchange is minimal at this time because the two cell layers of the villous membrane are too thick. Permeability increases as the cytotrophoblasts thins and disappears. By the 5th month, only the single layer of syncytium is left between the maternal blood and the fetal capillaries. The syncytium is the functional layer of the placenta. By the 8th week, genetic testing may be done on a sample of chorionic villi obtained by aspiration biopsy. However, limb defects have been associated with chorionic villi sampling done before 10 weeks. The structure of the placenta is complete by the 12th week. The placenta continues to grow wider until 20 weeks, when it covers about half of the uterine surface. It then continues to grow thicker. The branching villi continue to develop within the body of the placenta, increasing the functional surface. Functions. One of the early functions of the placenta is as an endocrine gland that produces 4 hormones necessary to maintain the pregnancy and support the embryo fetus. The hormones are produced in the syncytium. The protein hormone, human chorionic gonadotropin, or HCG, can be detected in the maternal serum by 8 to 10 days after conception, shortly after implantation. This hormone is the basis for pregnancy tests. The HCG preserves the function of the ovarian corpus luteum, ensuring a continued supply of estrogen and progesterone needed to maintain the pregnancy. Miscarriage occurs if the corpus luteum stops functioning before the placenta can produce sufficient estrogen and progesterone. The HCG reaches its maximum level at 50 to 70 days and then begins to decrease. The other protein hormone produced by the placenta is human chorionic somatomammotropin, or HCS, or human placental lactogen, or HPL. This substance is similar to a growth hormone and stimulates maternal metabolism to supply needed nutrients for fetal growth. This hormone increases the resistance to insulin, facilitates glucose transport across the placental membrane, and stimulates breast development to prepare for lactation. The placenta eventually produces more of the steroid hormone progesterone than the corpus luteum does during the first few months of pregnancy. Progesterone maintains the endometrium, decreases the contractility of the uterus, and stimulates development of breast alveoli and maternal metabolism. By 7 weeks after fertilization, the placenta is producing most of the maternal estrogens, which are steroid hormones. The major estrogen secreted by the placenta is estriol, whereas the ovaries produce mostly estradiol. Measuring estriol levels is a clinical assay for placental functioning. Estrogen stimulates uterine growth and uteral placental blood flow. It causes a proliferation of the breast glandular tissue and stimulates myometrial contractility. Placental estrogen production increases greatly toward the end of pregnancy. One theory for the cause of the onset of labor is the decrease in circulating the decrease of circulating levels of progesterone and the increased levels of estrogen. The metabolic functions of the placenta are respiration, nutrition, excretion, and storage. Oxygen diffuses from the maternal blood across the placental membrane into the fecal blood, and carbon dioxide diffuses in the opposite direction. In this way, the placenta functions as a lung for the fetus. Carbohydrates, proteins, calcium, and iron are stored in the placenta for ready access to meet fetal needs. Water, inorganic salts, carbohydrates, proteins, fats, and vitamins pass from the maternal blood supply across the placental membrane into the fetal blood, supplying nutrition. Water and most electrolytes with a molecular weight less than 500 readily diffuse through the membrane. Hydrostatic and osmotic pressures aid in the flow of water and some solutions. Facilitated and active transport assists in the transfer of glucose, amino acids, calcium, iron, and substances with higher molecular weights. Amino acids and calcium are transported against the concentration gradient between the maternal blood and fetal blood. The fetal concentration of glucose is lower than the glucose level in the maternal blood because of its rapid metabolism by the fetus. This fetal requirement demands larger concentrations of glucose than simple diffusion can provide. Therefore, maternal glucose moves into the fetal circulation by active transport. Penocytosis is a mechanism used for transferring large molecules such as albumin and gamma Y or globulins across the placental membrane. This mechanism conveys the maternal immunoglobulins that provide early passive immunity to the fetus. Okay, got a Red Bull. Feeling better now. Here we go. Carbohydrates, proteins, calcium, and iron are stored in the placenta for ready access to meet fetal needs. Water, inorganic salts, carbohydrates, proteins, fats, and vitamins pass from the maternal blood supply across the placental membrane into the fetal blood, supplying nutrition. Water and most electrolytes with a molecular weight less than 500 readily diffuse through the membrane. Hydrostatic and osmotic pressures aid in the flow of water in some solutions. Facilitated and active transport assist in the transfer of glucose, amino acids, calcium, iron, and substances with higher molecular weights. Amino acid and calcium are transported against the concentration gradient across the maternal blood and fetal blood. The fetal concentration of glucose is lower than the glucose level in the maternal blood because of its rapid metabolism by the fetus. This fetal requirement demands larger concentrations of glucose than simple diffusion can provide. Therefore, maternal glucose moves into the fetal circulation by active transport. Sorry, I read all that already. Penocytosis is a mechanism used for transferring large molecules such as albumin and gamma Y globulins, or gamma globulins, across the placental membrane. This mechanism conveys the maternal immunoglobulins that provide early passive immunity to the fetus. Metabolic waste products of the fetus cross the placental membrane from the fetal blood into the maternal blood. The maternal kidneys then excrete them. Many viruses can cross the placental membrane and infect the fetus. Some bacteria and protozoa first infect the placenta and then infect the fetus. Drugs can also cross the placental membrane and may harm the fetus. Caffeine, alcohol, nicotine, carbon monoxide, and other toxic substances in cigarette smoke and prescription and recreational drugs such as marijuana and cocaine readily cross the placenta. Although no direct link exists between the fetal blood in the vessels of the chorionic villi and the maternal blood in the intervillous space, only one cell layer separates them. Breaks occasionally occur in the placental membrane. Fetal erythrocytes then leak into the maternal circulation, and the mother may develop antibodies to the fetal red blood cells. This is often the way the Rh negative mother becomes sensitized to the erythrocytes of her Rh positive fetus. See the discussion of isoimmunization in chapter 28. Excuse me. Although the placenta and fetus are analogous to living tissue transplants, they are not destroyed by the host mother. Either the placental hormones suppress the immunologic response or the tissue evokes no response. Placental function depends on the maternal blood pressure supplying the circulation. Maternal arterial blood under pressure in the small uterine spiral arteries spurts into the intervillous space. See figure 811. As long as rich arterial blood continues to be supplied, pressure is exerted on the blood already in the intervillous space, pushing it toward drainage by the low-pressure uterine veins. At term gestation, 10% of the maternal cardiac output goes to the uterus. If there is interference with the circulation to the placenta cannot supply the embryo or fetus. Vasoconstriction, such as that caused by hypertension or cocaine use, diminishes uterine blood flow. Decreased maternal blood pressure or decreased cardiac output also diminishes uterine blood flow. When a woman lies on her back with the pressure of the uterus compressing the vena cava, blood return to the right atrium is diminished. See figure 18.4 in discussion of supine hypotension in chapter 11. Excessive maternal exercise that diverts blood to the muscles away from the uterus compromises placental circulation. Optimal circulation is achieved when the woman is lying at rest on her side. Decreased uterine circulation may lead to the intrauterine growth restriction of the fetus and infants who are small for gestational age. Uterine contractions seem to enhance the movement of blood through the intervillous spaces, aiding placental circulation. However, prolonged contractions or too short intervals between contractions during labor can reduce the blood flow to the placenta. Fetal maturation. The stage of the fetus lasts from 9 weeks, when the fetus becomes recognizable as a human being, until the pregnancy ends. Changes during the fetal period are not as dramatic because refinement of structure and function is taking place. The fetus is less vulnerable to teratogens, except for those that affect central nervous system functioning. Viability refers to the compatibility of the fetus to survive outside the uterus. In the past, the earliest age at which fetal survival could be expected was 28 weeks after conception. With modern technology and advances in maternal and neonatal care, I lost my spot. With modern technology and advances in modern neonatal care, viability is now possible at 20 weeks after conception, 22 weeks since LMP, fetal weight of 500 grams or more. The limitations on survival outside the uterus are based on central nervous system function and oxygenation capability of the lungs. Respiratory system. The respiratory system begins development during embryonic life and continues through fetal life and into childhood. The development of the respiratory tract begins in week 4 and continues through week 17 with formation of the larynx, trachea, bronchi, and lung buds. Between 16 and 24 weeks, the bronchi and terminal bronchioles enlarge and vascular structures and primitive alveoli are formed. Between 24 weeks and term birth, more alveoli form. Specialized alveolar cells, type 1 and type 2 cells, secrete pulmonary surfactants to line the interior of the alveoli. After 32 weeks, sufficient surfactant is present in developed alveoli to provide infants with a good chance of survival. Pulmonary surfactants. The detection of the presence of pulmonary surfactants, or surface active phospholipids, in amniotic fluid has been used to determine the degree of fetal lung maturity, or the ability of the lungs to function after birth. Lecithin, or L, is the most critical alveolar surfactant required for postnatal lung expansion. It is detectable at approximately 21 weeks and increases in amount after 24 weeks. Another pulmonary phospholipid, sphingomyelin, or S, remains constant in amount. Thus, the measure of lecithin is in relation to sphingomyelin, or the LS ratio, is used to determine fetal lung maturity. When the LS ratio reaches 2 to 1, the infant's lungs are considered to be mature. This occurs at approximately 35 weeks of gestation. Certain maternal conditions that cause decreased maternal placental blood flow, such as maternal hypertension, placental dysfunction, infection, or corticosteroid use, accelerate lung maturity. This apparently is caused by the resulting fetal hypoxia, which stresses the fetus and increases the blood levels of corticosteroids that accelerate alveolar and surfactant development. Conditions such as gestational diabetes and chronic glomerulonephritis can retard fetal lung maturity. The use of intrabronchial synthetic surfactant in the treatment of respiratory distress syndrome in the newborn has greatly improved the chances of survival for preterm infants. Fetal respiratory movements have been seen on ultrasound as early as week 11. These fetal respiratory movements may aid in development of the chest wall muscle and regulate lung fluid volume. The fetal lungs produce fluid that expands the air spaces in the lungs. The fluid drains into the amniotic fluid or is swallowed by the fetus. Before birth, secretion of lung fluid decreases. The normal birth process squeezes out approximately 1/3 of the fluid. Infants of cesarean births do not benefit from the squeezing process, thus they may have more respiratory difficulty at birth. The fluid remaining in the lungs at birth is usually resorbed into the infant's bloodstream within 2 hours of birth. Fetal circulatory system. The cardiovascular system is the first organ system to function in the developing human. Blood vessel and blood cell formation begin in the 3rd week and supply the embryo with oxygen and nutrients from the mother. By the end of the 3rd week, the tubular heart begins to beat, and the primitive cardiovascular system links the embryo, connecting stalk, chorion, and yolk sac. During the 4th and 5th weeks, the heart develops into a 4-chambered organ. By the end of the embryonic stage, the heart is developmentally complete. The fetal lungs do not function for respiratory gas exchange. Thus, a special circulatory pathway, the ductus arteriosus, bypasses the lungs. Oxygen-rich blood from the placenta flows rapidly through the umbilical vein into the fetal abdomen, figure 8.12. When the umbilical vein reaches the liver, it divides into 2 branches. One branch circulates some oxygenated blood through the liver. Most of the blood passes through the ductus venosus into the inferior vena cava. There it mixes with the deoxygenated blood from the fetal legs and abdomen on its way to the right atrium. Most of this blood passes straight through the right atrium and through the foramen ovale, an opening into the left atrium. There it mixes with a small amount of deoxygenated blood returning from the fetal lungs through the pulmonary veins. The blood flows into the left ventricle and is squeezed out into the aorta, where the arteries supply the heart, head, neck, and arms receive most of the oxygen-rich blood. This pattern of supplying the highest levels of oxygen and nutrients to the head, neck, and arms enhances the cephalocaudal or head-to-rump development of the embryo fetus. Deoxygenated blood returning from the head and arms enters the right atrium through the superior vena cava. This blood is directed downward into the right ventricle, where it is squeezed into the pulmonary artery. A small amount of blood circulates through the resistant lung tissue, but the majority follows the path with less resistance through the ductus arteriosus into the aorta, distal to the point of exit of the arteries supplying the head and arms with oxygenated blood. The oxygen-poor blood flows through the abdominal aorta into the internal iliac arteries, where the umbilical arteries direct most of it back through the umbilical cord to the placenta. Aha! That's how it happens. There, the blood gives up its waste and carbon dioxide in exchange for nutrients and oxygen. The blood remaining in the iliac arteries flows through the fetal abdomen and legs, ultimately returning through the inferior vena cava to the heart. The following three special characteristics enable the fetus to obtain sufficient oxygen from the maternal blood. 1. Fetal hemoglobin carries 20% to 30% more oxygen than maternal hemoglobin. 2. The hemoglobin concentration of the fetus is about 50% greater than that of the mother. And 3. The fetal heart rate is 110 to 160 beats a minute, making the cardiac output per unit of body weight higher than that of the adult. Gotcha. So, hematopoietic system. The hematopoiesis, the formation of blood, occurs in the yolk sac, beginning in the 3rd week. Hematopoietic stem cells seed the fetal liver during the 5th week, and hematopoiesis begins there during the 6th week. This accounts for the relatively large size of the liver between the 7th and 9th weeks. Stem cells seed the fetal bone marrow, spleen, and thymus, and lymph nodes between weeks 8 and 11. For more information about stem cells, see blah, 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 blah. The antigenic factors that determine blood type are present in the erythrocytes soon after the 6th week. For this reason, the Rh-negative woman is at risk for isoimmunization in any pregnancy that lasts longer than 6 weeks after fertilization. Okay. Hepatic system. The liver and biliary tract develop from the foregut during the 4th week of gestation. Hematopoiesis begins during the 6th week and requires that the liver be large. The embryonic liver is prominent, occupying most of the abdominal cavity. Bile, a constituent of meconium, begins to form in the 12th week. Glycogen is stored in the fetal liver beginning at week 9 or 10. At term, glycogen stores are twice those of the adult. Glycogen is the major source of energy for the fetus and for the neonate stressed by in utero hypoxia, extrauterine loss of the maternal glucose supply, the work of breathing, or cold stress. Iron is also stored in the fetal liver. If maternal intake is sufficient, the fetus can store iron to last for 5 months after birth. During fetal life, the liver does not have to conjugate bilirubin for excretion because the conjugated bilirubin is cleared by the placenta. Therefore, the glucuronil transferase enzyme needed for conjugation is present in the fetal liver in amounts less than those required after birth. This predisposes the neonate, especially the preterm infant, to hyperbilirubinemia. Okay. Coagulation factors 2, 7, 9, and 10 cannot be synthesized in the fetal liver because of the lack of vitamin K synthesis in the sterile fetal gut. This coagulation deficiency persists after birth for several days and is the rationale for the prophylactic administration of vitamin K to the newborn. Gastrointestinal system. During the 4th week, the shape of the embryo changes from being almost straight. The shape of the embryo changes from being almost straight to a C shape as both ends fold inwards, inward toward the ventricle surface. A portion of the yolk sac is incorporated into the body from head to tail as the primitive gut, or digestive system. The foregut produces the pharynx, part of the lower respiratory tract, the esophagus, the stomach, the first half of the duodenum, and the liver, the pancreas, and the gallbladder. These structures evolve during the 5th and 6th weeks. Malformation that can occur in these areas include esophageal atresia, hypertrophic pyloric stenosis, duodenal stenosis, or atresia, and biliary atresia. So duodenal stenosis or atresia and biliary atresia. The midgut becomes the distal half of the duodenum, and the jejunum and ileum, the cecum and appendix, and the proximal half of the colon. The midgut loop projects into the umbilical cord between weeks 5 and 10. A malformation omphalocele results in the midgut if the midgut fails to return to the abdominal cavity, causing the intestines to protrude from the umbilicus. Meckel diverticulum is the most common malformation of the midgut. It occurs when a remnant of the yolk stalk that has failed to degenerate attaches to the ileum, leaving a blind sac. The hindgut develops into the distal half of the colon, the rectum, and parts of the anal canal, and urinary bladder and the urethra. Anorectal malformations are the most common abnormalities of the digestive system. The fetus swallows amniotic fluid beginning in the 5th month. Gastric emptying and intestinal peristalsis occur. Fetal nutrition and elimination needs are taken care of by the placenta. As the fetus nears term, fetal waste products accumulate in the intestines as dark green to black tarry and meconium. Normally, this substance is passed through the rectum within 24 hours of birth, sometimes with a breech presentation or fetal hypoxia. Meconium is passed in utero into the amniotic fluid. The failure to pass meconium after birth may indicate atresia somewhere in the digestive tract and imperforate anus or meconium ileus, in which a firm meconium plug blocks passage, seen in infants with CF. Not sure what CF is. The metabolic rate of the fetus is relatively low, but the infant has great growth and development needs. Beginning in week 9, the fetus synthesizes glycogen for storage in the liver. Between 26 and 30 weeks, the fetus begins to lay down stores of brown fat in preparation for extrauterine cold stress. Their thermoregulation in the neonate requires increased metabolism and adequate oxygenation. The gastrointestinal system is mature by 36 weeks. Digestive enzymes, except pancreatic amylase and lipase, are present in sufficient quantity to facilitate digestion. The neonate cannot digest starches or fats efficiently. Little saliva is produced. Renal system. The kidneys form during the 5th week and begin to function approximately 4 weeks later. Urine is excreted into the amniotic fluid and forms a major part of the amniotic fluid volume. Oligohydramnios is indicative of renal dysfunction, so that's low amniotic fluid. Because the placenta acts as the organ of excretion and maintains fetal water and electrolyte balance, the fetus does not need functioning kidneys while in utero. However, at birth, the kidneys are required immediately for excretory and acid-based regulatory functions. A fetal renal malformation can be diagnosed in utero. Corrective or palliative fetal surgery may treat the malformation successfully, or plans can be made for treatment immediately after birth. At term, the fetus has fully developed kidneys. However, the glomerular filtration rate is low and the kidneys lack the ability to concentrate urine. This makes the newborn more susceptible to both overhydration and dehydration. Most newborns void within 24 hours of birth, with the loss of the swallowed amniotic fluid and the metabolism of nutrients provided by the placenta. Voidings for the first days of life are scant until fluid intakes increase. Neurologic system. The nervous system originates from the ectoderm during the 3rd week after fertilization. The open neural tube forms during the 4th week. It initially closes at what will be the junction of the brain and spinal cord, leaving both ends open. The embryo folds in on itself lengthwise at this time, forming a head fold in the neural tube at this junction. The cranial end of the neural tube closes. Then the caudal end closes. During week 5, different growth rates cause more flexures in the neural tube. During week 5. Okay, in the neural tube, delineating 3 brain areas: the forebrain, midbrain, and hindbrain. The forebrain develops into the eyes, cranial nerve 2, and cerebral hemispheres. The development of all areas of the cerebral cortex continues throughout fetal life and into childhood. The olfactory system, cranial nerve 1, and thalamus also develop from the forebrain. Cranial nerves 3 and 4, ocular, motor, and trochlear, form from the midbrain. The hindbrain forms the medulla, the pons, the cerebellum, and the remainder of the cranial nerves. Brainwaves can be recorded on an electroencephalogram by week 8. The spinal cord develops from the long end of the neural tube. Another ectodermal structure, the neural crest, develops into the peripheral nervous system. By the 8th week, nerve fibers traverse throughout the body. By week 11 or 12, the fetus makes respiratory movements, moves all extremities, and changes position in utero. The fetus can suck his or her thumb, swim in the amniotic fluid pool, and turn somersaults, and sometimes ties a knot in the umbilical cord. Sometime between 16 and 20 weeks, when the movements are strong enough to be perceived by the mother as the baby moving, quickening has occurred. The perception of movement occurs earlier in the multipara than in the primipara. The mother also becomes aware of the sleep and wake cycles of the fetus. Sensory awareness. Purposeful movements of the fetus have been demonstrated in response to a firm touch transmitted through the mother's abdomen. Because it can feel, the fetus requires anesthesia when invasive procedures are done. Fetuses respond to sound by 24 weeks. Different types of music evoke different movements. The fetus can be soothed by the sound of the mother's voice. Acoustic stimulation can be used to evoke a fetal heart rate response. The fetus becomes accustomed or habituates to noises heard repeatedly. Hearing is fully developed at birth. The fetus is able to distinguish taste. By the 5th month, when the fetus is swallowing amniotic fluid, a sweetener added to the fluid causes the fetus to swallow faster. The fetus also reacts to temperature changes. A cold solution placed into the amniotic fluid can cause fetal hiccups. The fetus can see. Eyes have both rods and cones in the retina by the 7th month. A bright light shown on the mother's abdomen in late pregnancy causes abrupt fetal movement. During sleep time, rapid eye movements have been observed, similar to those occurring in children and adults while dreaming. At term, the fetal brain is approximately 1/4 the size of an adult brain. Neurologic development continues. Stressors on the fetus and neonate, e.g. chronic poor nutrition or hypoxia, drugs, environmental toxins, trauma, and disease, cause damage to the CNS long after the vulnerable embryonic time for malformations in other organ systems. Neurologic insult can result in cerebral palsy, neuromuscular impairment, mental retardation, and learning disabilities. Endocrine system. The thyroid gland develops along with structures in the head and neck during the 3rd and 4th weeks. The secretion of thyroxine begins during the 8th week. Maternal thyroxine does not readily cross the placenta. Therefore, the fetus that does not produce thyroid hormones will be born with congenital hypothyroidism. If untreated, hypothyroidism can result in severe mental retardation. Screening for hypothyroidism is typically included in the testing when screening for PKU after birth. The adrenal cortex is formed during the 6th week and produces hormones by the 8th or 9th week. As term approaches, the fetus produces more cortisol. This is believed to aid in initiation of labor by decreasing the maternal progesterone and stimulating production of prostaglandins. The pancreas forms from the foregut during the 5th through the 8th weeks. The islets of Langerhans develop during the 12th week. Insulin is produced by week 20. In infants of mothers with uncontrolled diabetes, maternal hyperglycemia produces fetal hyperglycemia, stimulating hyperinsulinemia and islet cell hyperplasia. This results in macrosomatic or large-sized fetus. The hyperinsulinemia also blocks lung maturation, placing the neonate at risk for respiratory distress and hypoglycemia when the maternal glucose source is lost at birth. Control of the maternal glucose level before and during pregnancy minimizes problems for the fetus and infant. Reproductive system. Sex differentiation begins in the embryo during the 7th weeks. Female and male external genitalia are indistinguishable until about after the 9th week. Distinguishing characteristics appear around the 9th week and are fully differentiated by the 12th week. When a Y chromosome is present, testes are formed. By the end of the embryonic period, testosterone is being secreted and causes formation of the male genitalia. By week 28, the testes begin descending into the scrotum. After birth, low levels of testosterone continue to be secreted until the pubertal surge. A female with 2 X chromosomes forms ovaries and female external genitalia. By the 16th week, oogenesis has been established. At birth, the ovaries contain the female's lifetime supply of ova. Most female hormone production is delayed until puberty. However, the fetal endometrium responds to maternal hormones, and withdrawal bleeding or vaginal discharge or pseudomenstruation may occur at birth when these hormones are lost. The high level of maternal estrogen also stimulates mammary engorgement and secretion of fluids, or witch's milk, in newborn infants of both sexes. Ooh, that's weird. Witch's milk. Musculoskeletal system. Bones and muscles develop from the mesoderm by the 4th week of embryonic development. At that time, the cardiac muscle is already beating. The mesoderm, next to the neural tube, forms the vertebral column and ribs. The parts of the vertebral column grow toward each other to enclose the developing spinal cord. Ossification or bone formation begins. If there is a defect in the bony fusion, various forms of spina bifida may occur. A large defect affecting several vertebrae may allow the membrane and spinal cord to pouch out from the back, producing neurologic defects and skeletal deformity. The flat bones of the skull develop during the embryonic period, and ossification continues throughout childhood. At birth, connective tissue sutures exist where the bones of the skull meet. The areas where more than 2 bones meet, called fontanelles, are especially prominent. The sutures and fontanelles allow the bone of the skull to mold or move during birth, enabling the head to pass through the birth canal. The bones of the shoulders, arms, hips, and legs appear in the 6th week as a continuous skeleton with no joints. Differentiation occurs, producing separate bones and joints. Ossification continues through childhood to allow growth. Beginning in the 7th week, muscles contract spontaneously. Arm and leg movements are visible on ultrasound examination, although the mother does not perceive them until sometime between 16 and 20 weeks. Integumentary system. The epidermis begins as a single layer of cells derived from the ectoderm at 4 weeks. By the 7th week, there are 2 layers of cells. The cells of the superficial layer are sloughed and become mixed with the sebaceous gland secretions to form the white, cheesy vernix caseosa, the material that protects the skin of the fetus. The vernix is thick at 24 weeks but becomes scant by term. The basal layer of the epidermis is the germinal layer, which replaces lost cells. Until 17 weeks, the skin is thin and wrinkled, with blood vessels visible underneath. The skin thickens and all layers are present at term. After 32 weeks, as subcutaneous fat is deposited under the dermis, the skin becomes less wrinkled and red in appearance. By 16 weeks, the dermal ridges are present on the palms of the hands, the fingers, the bottoms of the feet, and the toes. These handprints and footprints are unique to that infant. Hairs form from hair bulbs in the epidermis that project into the dermis. Cells in the hair bulb keratinize to form the hair shaft. As the hairs at the base of the hair shaft proliferate, the hair grows to the surface of the epithelium. Fine hairs called lanugo appear first at 12 weeks on the eyebrows and upper lip. By week 20, they cover the entire body. At this time, the eyelashes Eyebrows and scalp hair are beginning to grow. By week 12, the scalp hair is longer than the lanugo, which thins and may disappear by term gestation. Fingernails and toenails develop from thickened epidermis at the tips of the digits beginning during the 10th week. They grow slowly. Fingernails usually reach the fingertips by 32 weeks, and toenails reach toe tips by 36 weeks. Oh, little toenails. Immunologic system. During the third trimester, albumin and globulin are present in the fetus. The only immunoglobulin that crosses the placenta, IgG, provides passive acquired immunity to specific bacterial toxins. The fetus produces IgM by the end of the first trimester. This is produced in response to blood group antigens, gram-negative enteric organisms, and some viruses. IgA is not produced by the fetus. However, colostrum, the precursor to breast milk, contains large amounts of IgA and can provide passive immunity to the neonate who is breastfed. The normal-term neonate can fight infection, but not as effectively as an older child. The normal-term neonate can fight infection, but not as effectively as an older child. The preterm infant is at much greater risk for infection. Table 8.1 summarizes embryonic and fetal development. Okay, and multifetal pregnancy, twins. The incidence of twinning is 1 in 43 pregnancies. There has been a steady rise in multiple births since 1973. This is partly attributed to delayed childbirth. The use of ovulation-enhancing drugs is also a factor. Multifetal pregnancy. Oh wait, no, I already said dizygotic twins. When two mature ova are produced in one ovarian cycle, both have the potential to be fertilized by separate sperm. This results in two zygotes, or dizygotic twins. Okay, there are also two amnions, two chorions, and two placentas that may be fused together. These dizygotic or fraternal twins may be the same sex or different sexes and are genetically no more alike than siblings born at different times. Dizygotic twinning occurs most often in families with a history of twinning, is more common among African American women than Caucasian women, and is least common among Asian American women. Dizygotic twinning increases in frequency with maternal age up to 35 years, with parity, and with the use of fertility drugs. Monozygotic twins, identical or monozygotic twins, develop from one fertilized ovum, which then divides. They are the same sex and have the same genotype. If division occurs soon after fertilization, two embryos, two amnions, two chorions, and two placentas that may be fused will develop. Most often, division occurs between 4 and 8 days after fertilization. There are two embryos, two amnions, one chorion, and one placenta. Rarely division occurs after the 8th day following fertilization. In this case, there are two embryos with a common amnion and a common chorion with one placenta. This often causes circulatory problems because the umbilical cords may tangle together and one or both fetuses may die. If division occurs very late, cleavage may not be complete and conjoined or Siamese twins could result. Monozygotic twinning occurs in approximately 1 in 250 births. There is no association with race, heredity, maternal age, or parity. Fertility drugs also increase the incidence of monozygotic twinning. Okay, and that was for, what was that, conception. Woohoo! Okay, on to prenatal screening, 190 to 198 and 203 to 206. Antepartum testing and biophysical assessment. The major expected outcome of antepartum testing is the detection of potential fetal compromise. Ideally, the technique used will identify fetal compromise before intrauterine asphyxia of the fetus occurs so that the health care provider can take measures to prevent or minimize adverse perinatal outcomes. No single test can provide this information. Assessment tests should be selected based on their effectiveness, and the results must be interpreted in light of the complete clinical picture. The most reliable evidence for effectiveness is provided by randomized controlled trials. Nurses can be informed about the most recent research on fetal assessment by using an up-to-date systematic review such as the Cochrane Database of Systematic Reviews. Box 9.6 lists evidence for recommending care for fetal assessment screening based on this database. So, box 9.1, we're going to do high-risk factors. Genetic factors. Genetic considerations. Genetic factors may interfere with normal fetal or neonatal development, result in congenital anomalies, or create difficulties for the mother. These factors include defective genes, transmittable inherited disorders, chromosome anomalies, multiple pregnancies, large fetal size, and ABO incompatibility. Is that blood type, I guess? A genetic risk assessment should be done to determine the family's heritable risk. Demographic characteristics. Geographic location. The availability and quality of prenatal care vary greatly with geographic region. Women in metropolitan areas have more prenatal visits than those in rural areas, who have fewer opportunities for specialized care and consequently a higher incidence of maternal mortality. Health care in an inner city where residents are usually poorer and begin childbearing earlier and continue for longer may be of lower quality than in a more affluent neighborhood. There may be unsafe soil and water conditions and environmental exposures to pollutants. Socioeconomic status. Poverty underlies many other risk factors and leads to inadequate financial resources for food and prenatal care. Poor general health, increased risk for medical complications of pregnancy, and greater prevalence of adverse environmental influences such as substandard living conditions, poor hygiene, and inadequate nutrition. Educational attainment. Risk for adverse perinatal outcomes decreases as educational level increases. Risk for adverse perinatal outcomes decreases, as educational level increases. Marital status. The increased mortality and morbidity rates for unmarried women, including a greater risk for preeclampsia, are often related to inadequate prenatal care and a younger childbearing age. Maternal age. Mothers younger than 20 years and older than 34 years have a slight increase in adverse perinatal outcomes. Racial and ethnic origins. Although race and ethnicity by themselves are not major risks, race as an indicator of socioeconomic demographic risk factors. Non-Caucasian women are more than 3 times as likely as Caucasian women to die of pregnancy-related causes. African American babies have the highest rates of prematurity and low birth weights, and the infant mortality rates among African Americans being more than double that among Caucasians. Occupational hazards. Occupational hazards can be grouped into chemical, physical, biologic, and psychological hazards. The risk to the fetus depends on the timing of exposure, the dose, and the fetal and maternal susceptibility. Behavioral characteristics. Smoking, substance abuse. Smoking is associated with intrauterine growth restrictions and low birth weight. Alcohol exerts adverse effects on the fetus, resulting in fetal alcohol spectrum disorders, which include fetal alcohol syndrome, alcohol-related neurodevelopment disorder, and alcohol-related birth defects. Drugs can be teratogenic, cause metabolic disturbances, produce chemical effects, or cause depression or alteration of central nervous system function. Failure to seek prenatal care. Failure to diagnose and treat complications early is a major risk factor arising from financial barriers or lack of access to care. Depersonalization of the system resulting in long waits, routine visits, variability in healthcare personnel, and unpleasant physical surroundings. Lack of understanding of the need for early and continued care or cultural beliefs that do not support the need, and fear of the healthcare system and its providers. Nutritional status. Adequate nutrition, without which fetal growth and development cannot proceed normally, is one of the most important determinants of pregnancy outcome. Conditions that influence nutritional status include the following: young age, 3 pregnancies in the previous 2 years, tobacco, alcohol, or drug use, inadequate dietary intake because of chronic illness or food fads, inadequate or excessive weight gain, and hematocrit value less than 32%. Dental hygiene. Periodontal disease increases the risk for preterm birth and low birth weight. Who knew? Psychosocial stressors. Childbirth triggers profound and complex physiologic, psychologic, and social changes with evidence to suggest a relationship between emotional distress and birth complications. This risk factor includes conditions such as specific intrapsychic disturbances and addictive lifestyles, a history of child or spouse abuse, inadequate support systems, family disruption or dissolution, maternal role changes or conflicts, non-compliance with cultural norms, unsafe cultural, ethnic, or religious practices, and situational crises. Abuse and violence. Domestic violence is a serious problem. The risk of violence increases drug pregnancy abuse. Abuse during pregnancy increases the risk for abruptio placenta, preterm birth, and low birth weight infants and infections from forced sex. Okay, wow, that was so just obvious stuff. Okay, sorry. So, daily fetal movement count. Assessment of fetal activity by the mother is a simple yet valuable method for monitoring the condition of the fetus. The daily fetal movement count, or DFMC, also called kick counts, can be done at home. It is simple to understand, it is non-invasive, and usually does not interfere with the daily routine. The DFMC is frequently used to monitor the fetus in pregnancies complicated by conditions that may affect fetal oxygenation. These conditions include, but are not limited to, gestational hypertension or chronic hypertension and diabetes. The presence of movements in generally a reassuring sign of fetal health. Women should be taught the significance of the presence and or absence of FMs, the procedure to use for counting, how to record findings on a daily FM record, and when to notify their healthcare provider. Figure 9.1, page 195. So, several protocols are used for counting. One recommendation is to count all fetal movements in a 12-hour period each day until a minimum of 10 movements are counted. Another common recommendation is that mothers count fetal activity 2 or 3 times daily, e.g. after meals or before bedtime, for 2 hours or until 10 movements are counted, except for noting a very low number of daily fetal movements or a trend toward decreased motion. The clinical value of the absolute number of FMs has not been established. The only exception is if FMs cease entirely for 12 hours, the so-called fetal alarm signal. If fewer than 10 FMs are felt within a specified time or movement is perceived to be less than the previous day, the woman should notify her healthcare provider for further evaluation. Nursing alert. In assessing FMs, it is important to remember that they are usually not present during the fetal sleep cycle. They may be temporarily reduced if the woman is taking depressant medication, drinking alcohol, or smoking a cigarette. They do not decrease as the woman nears term. Obesity decreases perception of FM and consequently the ability of the mother to count FMs. Okay, ultrasonography. Sound is a form of wave energy that causes small particles in a medium to oscillate. The frequency of sound, which refers to the number of peaks or waves that move over a given point per unit of time, is expressed in hertz. Sound with a frequency of 1 cycle or 1 peak per second has a frequency of 1 hertz. When directional beams of sound strike an object, an echo is returned. The time delay between the emission of the sound and the return of the echo and the direction of the echo are noted. From these data, the distance and location of an object can be calculated. Ultrasound is a sound frequency higher than that detectable by humans, greater than 20,000 hertz. Diagnostic ultrasound instruments operate within a frequency range of 2 to 10 million hertz, which is below the range used by sonar and radar equipment. Ultrasound images are a reflection of the strength of the sending beam, the strength of the returning echo, and the density of the medium, e.g. muscle, uterus, bone, tissue, placenta, fluid, or blood, through which the beam is sent and returned. Diagnostic ultrasonography is an important technique in antepartum fetal surveillance. It provides critical information to healthcare providers regarding fetal activity and gestational age, normal versus abnormal fetal growth curves, visual assistance with which invasive tests may be performed more safely, fetal and placental anatomy, and fetal well-being. Ultrasound examinations can be done abdominally or transvaginally during pregnancy. Both methods produce a three-dimensional view from which a pictorial image is obtained. Abdominal ultrasonography is more useful after the first trimester when the pregnant uterus becomes an abdominal organ. For the procedure, the woman is usually required to have a full bladder to push the uterus up to get a better image of the fetus. Transmission gel or paste is applied to the abdomen before a transducer is moved over the skin to enhance transmission and reception of the sound waves. She is positioned with small pillows under her head and knees. The display panel is positioned so that the woman or her partner can observe the images on the screen if they desire. Transvaginal ultrasonography is in which the probe is inserted into the vagina, allows pelvic anatomy to be evaluated in greater detail, and allows intrauterine pregnancy to be diagnosed earlier. Transvaginal ultrasonography is used in the first trimester to detect ectopic pregnancies, monitor the developing embryo, help identifying abnormalities, and help establish gestational age. In some instances, it may be used as an adjunct to abdominal scanning to evaluate preterm labor in second and third trimester pregnancies. A transvaginal ultrasound examination is well tolerated by most patients because it alleviates the need for a full bladder. It is especially useful in obese patients whose thick abdominal layers cannot be penetrated adequately with an abdominal approach. A transvaginal ultrasound may be performed either with the woman in a lithotomy position or with her pelvis elevated by towels, cushions, or a folded pillow. This pelvic tilt is optimal to image the pelvic structures. A protective cover such as a condom, the finger of a clean rubber surgical glove, or a special cover provided by the manufacturer is used to cover the probe. The probe is lubricated with a water-soluble gel and placed in the vagina, either by the examiner or by the woman herself. During the examination, the position of the probe or the tilt of the examining table may be changed to view the complete pelvis. The procedure is not physically painful, although the woman will feel pressure as the probe is moved. Levels of ultrasonography. The American College of Obstetricians and Gynecologists describes 3 levels of ultrasonography. The standard examination is used most frequently and can be performed by ultrasonographers or other healthcare professionals, including nurses who have had special training. Indications for standard ultrasonography are described in detail in the next section. Its primary purposes are to detect fetal viability, determine the presentation of the fetus, assess gestational age, locate the placenta, examine the fetal anatomy for malformations, and determine amniotic fluid volume, AFV. Limited examinations are performed for specific indications, such as identifying fetal presentation during labor or evaluating fetal heart activity when it is not detected by other methods. Specialized or targeted examinations are performed if a woman is suspected of carrying an anatomically or physiologically abnormal fetus. Indications for a comprehensive examination include abnormal findings on clinical examination, especially with polyhydramnios or oligohydramnios, elevated alpha fetoprotein or AFP levels, and a history of offspring with abnormality or anomalies that can be detected by ultrasound examination. Specialized ultrasonography is performed by highly trained and experienced personnel. Indications for use. Major indications for the use of obstetric sonography are shown by trimester in box 9.7. Ultrasonography can lead to earlier diagnosis, allowing therapy to be instituted early in the pregnancy. This decreases the severity and duration of morbidity, both physical and emotional, for the family. For example, early diagnosis of a fetal anomaly gives the family choices such as 1. Preparation for the care of an infant with a disorder, intrauterine surgery or other therapy for the fetus, or termination of the pregnancy. Fetal heart activity. Fetal heart activity can be demonstrated as early as 6 to 7 weeks by real-time echo scanners and at 10 to 12 weeks by Doppler mode. By 9 to 10 weeks, gestational trophoblastic disease can be diagnosed. Fetal death can be confirmed by lack of heart motion, the presence of fetal scalp edema, and maceration and overlap of the cranial bones. Gestational age. Gestational dating by ultrasonography is indicated for conditions such as the following: 1. Uncertain dates for the last normal menstrual period. 2. Recent discontinuation of oral contraceptives. 3. Bleeding episode during the first trimester. And 4. Uterine size that does not agree with dates and other high risk conditions. During the first 20 weeks of gestation, ultrasonography provides an accurate assessment of gestational age because most normal fetuses grow at the same rate. With increased fetal age, the accuracy of gestational age estimates using ultrasound also increases because more variables are measured. 4 methods of fetal age estimation are used. 1. Determination of gestational sac dimensions at about 8 weeks. 2. Measurement of crown rump length between 5 to 10 weeks. 3. Measurement of the biparietal diameter, or the BPD, after 12 weeks. And 4. Measurement of femur length after 12 weeks. Fetal BPD at 36 weeks should be approximately 8 to 7 centimeters. Biparietal diameter, okay, 8 to 7 centimeters. Term pregnancy and fetal maturity can be diagnosed with some confidence if the biparietal measurement by ultrasound is greater than 9 to 8 centimeters, especially when this is combined with appropriate femur length measurement. Fetal growth. Fetal growth is determined by intrinsic growth potential and the environmental factors that may enhance or inhibit that growth. Conditions that indicate the need for ultrasound assessment of fetal growth include the following: 1. Poor maternal weight gain or pattern of weight gain. 2. Previous pregnancy with intrauterine growth restriction, IUGR. 3. Chronic infections. 4. Ingestion of drugs, tobacco, alcohol, over-the-counter drugs, and street drugs. 5. Maternal diabetes mellitus. 6. Hypertension. 7. Multi-fetal pregnancy. 8. Other medical or surgical complications. Serial evaluations of BPD, head circumference, limb length, and abdominal circumference can differentiate among size discrepancy resulting from inaccurate dates, true IUGR, and macrosomia. IUGR may be symmetric, or meaning the fetus is small in all parameters, or asymmetric, head and body growth vary. Symmetric IUGR implies a chronic or long-standing insult and may be caused by low genetic growth potential, intrauterine infection, undernutrition, heavy smoking, or chromosome aberration. Asymmetric growth reflects an acute or late occurring deprivation such as placental insufficiency resulting from hypertension, renal disease, or cardiovascular disease. Okay. Reduced fetal growth is still one of the most frequent conditions associated with stillbirth. Macrosomic infants, those weighing 4,000 grams or more, are at increased risk for dystocia, I don't know what that is, traumatic injury, and asphyxia during birth. Fetal macrosomia associated with maternal glucose intolerance or diabetes carries an increased risk of intrauterine fetal death. Macrosomia in the infant or of a mother with diabetes is asymmetric and characterized by increases in fat and muscle in the abdomen and shoulders. Head circumference remains normal. Macrosomia is an infant whose mother is obese without glucose intolerance results in symmetric changes. Okay, just a big baby, i.e. excessive growth of abdominal and head circumferences. Big old baby. Fetal anatomy. Depending on the gestational age, the following structures can be identified by ultrasonography: head, including ventricles and blood vessels; neck, spine, heart, stomach, small bowel, liver, kidneys, bladder, limbs, and umbilical cord. Ultrasonography permits the confirmation of normal anatomy and the detection of major fetal malformations. The presence of an anomaly may influence the birth location, e.g., a delivery room instead of a labor delivery recovery room, or a subspecialty center versus a basic care center, and the method of birth to optimize neonatal outcomes, vaginal versus cesarean. The number of fetuses and their presentation also may be assessed by ultrasonography, allowing plans for therapy and mode of birth to be made in advance. Fetal genetic disorders and physical anomalies. A prenatal screening technique called fetal nuchal, NUCHAL, translucency, or FNT screening uses ultrasound measurement of fluid in the nape of the fetal neck between 10 and 14 weeks of gestation to identify possible fetal abnormalities. A finding of abnormal fluid collection that is greater than 2.5 millimeters is considered abnormal, whereas a measurement of 3 millimeters or greater is highly indicative of genetic disorders or physical anomalies. If the FNT is abnormal, diagnostic genetic testing is recommended. Placental position and function. The pattern of uterine and placental growth and the fullness of the maternal bladder influence the apparent location of the placenta as viewed by ultrasonography. Okay. During the first trimester, differentiation between the endometrium and the small placenta is difficult. By 14 to 16 weeks, the placenta is clearly defined, but its relationship to the internal cervical OS can sometimes be altered dramatically by changing the degree of fullness of the maternal bladder. In approximately 15% to 20% of all pregnancies in which ultrasound scanning is performed during the second trimester, the placenta seems to be overlying the OS, but at term the incidence of placental previa the incidence of placenta previa at term is only 0.5%. Thus, the diagnosis of placenta previa can seldom be confirmed before 27 weeks, primarily because the elongation of the lower uterine segment as pregnancy advances. Another use of ultrasonography is grading of placental maturation. Calcium deposits are of significance in post-term pregnancies because as they increase, the available surface area that could be adequately bathed by maternal blood decreases. The point at which this results in fetal wastage and hypoxia cannot be determined precisely. However, effects usually are observable by 42 weeks and are progressive. Adjunct to amniocentesis, percutaneous umbilical blood sampling, and chorionic villus sampling. The safety of amniocentesis is increased when the exact position of the fetus, placenta, and pockets of amniotic fluid can be identified accurately. Ultrasound scanning has reduced the risks previously associated with amniocentesis, such as fetomaternal hemorrhage from a pierced placenta, percutaneous umbilical cord sampling, or PUBS, and chronic villus sampling, CVS, are also guided by ultrasonography to accurately identify the cord and chorion frondosum. Okay. Fetal well-being. Physiologic parameters of the fetus that can be assessed with ultrasound scanning include amniotic fluid volume, vascular waveforms from the fetal circulation, heart motion, fetal breathing movements, fetal urine production, and fetal limb and head movements. Assessment of these parameters singly or in combination yields a fairly reliable picture of the fetal well-being. The significance of these findings is discussed in the following sections. Amniotic fluid volume, abnormalities in amniotic fluid volume, AFV, are frequently associated with fetal disorders. Subjective determinants of oligohydramnios, decreased fluid, include the absence of fluid pockets in the uterine cavity and the impression of crowding of fetal small parts, arms and legs, and objective criterion of decreased AFV is met when the largest pocket of fluid, measured in two perpendicular planes, is less than 2 centimeters. In the case of polyhydramnios, or increased fluid, the criteria include multiple large pockets of fluid, the impression of a floating fetus, and free movement of fetal limbs. The diagnosis may be made when the largest pocket of fluid exceeds 8 centimeters in one vertical pocket. The total AFV can be evaluated by a method in which the depths in centimeters of amniotic fluid in all 4 quadrants surrounding the maternal umbilicus are totaled, resulting in an amniotic fluid index, AFI. An AFI of less than 5 centimeters indicates oligohydramnios. 5 to 19 is considered a normal measurement, and a measurement greater than 20 centimeters reflects polyhydramnios. Oligohydramnios is associated with rupture of the membranes and congenital anomalies, such as renal agenesis, agenesis, IUGR, and fetal distress in labor. Polyhydramnios is associated with neural tube defects, NTDs, obstruction of the fetal gastrointestinal tract, and multiple fetuses and fetal hydrops. Doppler blood flow analysis. One of the major advances in prenatal medicine is the ability to study blood flow non-invasively in the fetus and placenta with ultrasonography. Doppler blood flow analysis is a useful adjunct in the management of pregnancies at risk because of hypertension, IUGR, diabetes mellitus, multiple fetuses, or preterm labor. When a sound wave is reflected from a moving target, there is a change in frequency of the reflected wave relative to the transmitted wave. This is called the Doppler effect. An ultrasound beam scattered by a group of red blood cells, RBCs, is an example of this effect. The velocity of the RBCs can be determined by measuring the change in the frequency in the sound wave reflected off the cells. This shifted frequency can be displayed as a plot velocity versus time, and the shape of these waveforms can be analyzed to give information about blood flow and resistance in a given circulation. Velocity waveforms from umbilical and uterine arteries reported in systolic-diastolic, or SD, ratios can be first detected at 15 weeks of pregnancy. Because of progressive decline in resistance in both the umbilical and the uterine arteries, this ratio decreases as pregnancy advances. Most fetuses achieve an SD ratio of 3 or less by 30 weeks. Persistent elevation of SD ratios after 30 weeks is associated with IUGR, usually resulting from uteroplacental insufficiency. In post-term pregnancies, evaluated by Doppler umbilical flow studies, an elevated SD ratio indicates a poorly perfused placenta. Abnormal velocity study results are also seen with certain chromosome abnormalities, trisomy 13 and 18, and with lupus erythematosus in the mother. Exposure to nicotine from maternal smoking also increases the SD ratio. Biophysical profile. Real-time ultrasound permits detailed assessment of the physical and physiologic characteristics of the developing fetus to such an extent that it is possible to examine the fetus in detail and to catalog normal and abnormal biophysical responses to stimuli. The biophysical profile, or BPP, is a non-invasive dynamic assessment of a fetus that is based on the assessment of acute and chronic markers of the fetal disease. The BPP includes fetal breathing movements, FMs, fetal tone, fetal heart rate, or FHR, patterns by means of a non-stress test, or NST, and AFV. The BPP may be considered as a physical examination of the fetus, including determination of vital signs. The fetus responds to central hypoxia by alteration in movement, muscle tone, breathing, and heart rate patterns. The presence of normal fetal biophysical activities indicates that the central nervous system is functional. Therefore, the fetus is not hypoxemic. BPP variables and scoring are detailed in Table 9.1. The BPP is an accurate indicator of impending fetal death. Fetal acidosis can be diagnosed by early with a non-reactive NST and absent fetal breathing movements. An abnormal score and oligiohydramnios indicate labor should be induced. Fetal infection in women whose membranes rupture prematurely at less than 37 weeks of gestation can be diagnosed early by changes in biophysical activities that precede the clinical signs of infection and indicate the necessity for immediate birth. When BPP score is normal and the risk for fetal death low, intervention is indicated only for obstetric or maternal factors. Okay, on to 203 to 206. Yeah, more prenatal screening. Percutaneous umbilical cord sampling. Direct access to the fetal circulation during the second and third trimesters is possible through PUBS, or cordocentesis. PUBS is the most widely used method for fetal blood sampling and transfusion. It involves the insertion of a needle directly into the fetal umbilical vessel under ultrasound guidance. Ideally, the umbilical cord is punctured 1 to 2 centimeters from its insertion into the placenta. Figure 9.9. At this point, the cord is well anchored and will not move, and the risk of maternal blood contamination from the placenta is slight. Generally, 1 to 4 milliliters of blood is removed and tested immediately by the Kleicher-Betke procedure to ensure that it is fetal blood. Indications for use of PUBS includes prenatal diagnosis of inherited blood disorders, karyotyping of malformed fetuses, detection of fetal infection, determination of the acid-base status of fetus for IUGR, and assessment and treatment of isoimmunization and thrombocytopenia in the fetus. Complications that can occur include leaking of blood from the puncture site, cord laceration, thromboembolism, preterm labor, premature rupture of membranes, and infection. In fetuses at risk for isoimmune hemolytic anemia, PUBS permits precise identification of fetal blood type and RBC count and may eliminate the need for further intervention. If the fetus is positive for the presence of maternal antibodies, a direct blood test can confirm the degree of anemia resulting from hemolysis. Intrauterine transfusion of several anemic fetuses can be done 4 to 5 weeks earlier than through the intraperitoneal route. Follow-up includes continuous FHR monitoring for several minutes to 1 hour and a repeat ultrasound examination 1 hour later to ensure that no bleeding or hematoma formation has occurred. Chorionic villus sampling. The combined advantages of earlier diagnosis and rapid results have made chorionic villus sampling, or CVS, a popular technique for genetic studies. Although some risks to the fetus exist, indications for CVS are similar to those for amniocentesis. However, second trimester amniocentesis appears to be safer than CVS. The benefits of early diagnosis must be weighed against the increased risk of pregnancy loss and risk of anomalies. The procedure is performed between 10 and 12 weeks of gestation and involves the removal of a small tissue specimen from the fetal portion of the placenta. Because chorionic villi originate in the zygote, that tissue reflects the genetic makeup of the fetus. CVS can be accomplished either transcervically or transabdominally. In transcervically sampling, a sterile catheter is introduced into the cervix under continuous ultrasonographic guidance, and a small portion of the chorionic villi is aspirated with a syringe. The aspiration cannula and obturator must be placed at a suitable site, and rupture of the amniotic sac must be avoided. If the abdominal approach is used, an 18-gauge spinal needle with a stylet is inserted under sterile conditions through the abdominal wall into the chorion frondosum under ultrasound guidance. The stylet is then withdrawn and the chorionic tissue is aspirated into a syringe. Complications of the procedure include vaginal spotting or bleeding immediately afterward, miscarriage, that would be 0.3%, rupture of membranes, brains, 0.1%, and chorioamniotitis would be 0.3%. Also, because of the possibility of fetal-maternal hemorrhage, women who are Rh negative should receive immunoglobulin to avoid isoimmunization. An increased risk of limb anomalies, transverse digital anomalies, has been noted when CVS is done before 10 weeks of gestation. Use of amniocentesis in CVS is declining because of the advances of non-invasive screening techniques. These techniques include measurement of nuchal translucency, maternal serum screening tests in the first and second trimesters, and ultrasonography in the second trimester. Maternal assays, alpha fetoprotein, maternal serum AFP, MSAFP levels are used as a screening tool for NTDs and pregnancy. NTDs, forgot what those are. And open abdominal wall defects can be detected early. Through this technique, approximately 80 to 85% of all NTDs and open abdominal wall defects can be detected early in pregnancy. Screening is recommended for all pregnant women. The cause of NTDs is not well understood, but 95% of all affected infants are born to women with no family history of similar anomalies. The defects occur in 1 to 2 per 1,000 births in most parts of the United States. The birth of one afflicted child increases the risk of NTD recurrence in future pregnancies. AFP is produced by the fetal liver and is detectable in increasing quantities in the serum of pregnant women from 14 to 34 weeks. Although amniotic fluid, AFP is diagnostic for NTD, MSAFP is a screening tool only and identifies candidates for the more definitive procedures of amniocentesis and ultrasound examination. MSAFP screening can be done with reasonable reliability any time between 15 and 22 weeks of gestation, 16 to 18 weeks being ideal. Down syndrome and probably other autosomal trisomies is associated with lower than normal levels of MSAFP and amniotic fluid AFP. The triple marker test is also performed at 16 to 18 weeks of gestation and uses the levels of 3 maternal serum markers, MSAFP, unconjugated estriol, and human chorionic gonadotropin, or HCG, in combination with maternal age to calculate a new risk level. If a fetus has Down syndrome, the MSAFP and conjugated estriol levels are low and the HCG level is elevated. With these 2 additional screening tests, approximately 60% of fetuses with Down syndrome can be identified. Other maternal markers are being investigated as predictors of fetal anomalies as well. Serum pregnancy-associated placental protein A is low in Down syndrome, whereas another substance, inhibin A, is elevated in Down syndrome and other trisomies. As with MSAFP, these tests are screening procedures only and are not diagnostic. A definitive examination of amniotic fluid for AFP and chromosome analysis, combined with ultrasound visualization of the fetus is necessary for diagnosis. A Combs test. The indirect Combs test is a screening test for Rh incompatibility and is discussed in Chapter 28. If the maternal titer for Rh antibodies is greater than 1 to 8 ratio, amniocentesis for determination of bilirubin in amniotic fluid is indicated to determine the severity of fetal hemolytic anemia. The Combs test can also detect other antibodies that may place the fetus at risk for incompatibility with the maternal antigens. Antepartal assessment. Antepartal or antepartum assessment tool or assessment using electronic fetal monitoring. Indications. Assessment during the first and second trimesters is directed primarily at the diagnosis of fetal anomalies. The goal of third trimester testing is to determine whether the intrauterine environment continues to be supportive to the fetus. The testing is often used to determine the timing of childbirth for patients at risk for uteral placental insufficiency. Gradual loss of placental function results first in inadequate nutrient delivery to the fetus, leading to IUGR. Subsequently, respiratory function is compromised, resulting in fetal hypoxia. Indications of the NST and the contraction stress test, or CST, are listed in box 911. No clinical contraindications exist for the NST, but results may be inconclusive if gestation is 26 weeks or less. Absolute contraindications for the CST are rupture of membranes, previous classic incision for cesarean birth, preterm labor, placenta previa, and abruptio placenta. Multi-fetal pregnancies, previous preterm labor, hydramnios, more than 36 weeks of gestation, and incomplete cervix are related contraindications for the CST. As a rule, reactive patterns with the NST or negative results with the CST are associated with favorable outcomes. That was a lot of jargon. I don't even think I got all that. Fetal responses to hypoxia and asphyxia. Observable fetal responses to hypoxia or asphyxia are the clinical basis for testing with EFM. Maybe going to explain what EFM is now? Oh, electronic fetal monitoring. Okay. Hypoxia or asphyxia elicits a number of responses in the fetus. There is a redistribution of blood flow to certain vital organs. This series of responses, or redistribution of blood flow favoring vital organs, decreased total oxygen consumption, and a switch to anaerobic glycolysis, is a temporary mechanism that enables the fetus to survive up to 30 minutes with limited oxygen supply without decompensation of vital organs. However, during more severe asphyxia or sustained hypoxemia, these compensatory responses are no longer maintained, and a decrease in the cardiac output, arterial blood pressure, and blood flow to the brain and heart occurs, with characteristic FHR patterns reflecting these changes. Variability. Okay. Considerable evidence supports the clinical belief that FHR variability indicates an intact nervous pathway through the cerebral cortex, midbrain, vagus nerve, and cardiac conduction system. With 98% accuracy in predicting fetal well-being, the presence of normal FHR variability is a reassuring indicator. Input from various areas of the brain decrease after cerebral asphyxia, leading to a decrease in variability after failure of the fetal hemodynamic compensatory mechanisms to maintain cerebral oxygenation. Okay. Non-stress test. The NST is the most widely applied technique for antepartum evaluation of the fetus. The basis for the NST is that the normal fetus produces characteristic heart rate patterns in response to fetal movements. In the healthy fetus with an intact central nervous system, 90% of gross fetal body movements are associated with fetal heart rate accelerations. The acceleration with movement response may be blunted by hypoxemia, acidosis, drugs, analgesics, barbiturates, and beta blockers. Fetal sleep and some congenital anomalies also. The NST can be performed easily and quickly in an outpatient setting because it is non-invasive, relatively inexpensive, and has no known contraindications. Disadvantages center around the high rate of false positive results for non-reactivity as a result of fetal sleep cycles, chronic tobacco smoking, medications, and fetal immaturity. The test is slightly less sensitive in detecting fetal compromise than are the CST or BPP. Procedure. The woman is seated in a reclining chair or in a semi-Fowler's position, with a light left tilt to optimize uterine perfusion and avoid supine hypotension. The FHR is recorded with a Doppler transducer and a dynamometer is applied to detect uterine contractions or fetal movements. The tracing is observed for signs of fetal activity and a concurrent acceleration of FHR. If evidence of FM is not apparent on the strip, the woman may be asked to press a button on a handheld event marker connected to the monitor when she feels FM. Fetal movement. The movement is then noted on the tracing because almost all accelerations are accompanied by FMs. The movements need not be recorded for the test to be considered reactive. The test usually is completed in 20 to 30 minutes, but it may take longer if the fetus must be awakened from a sleep state. It has been suggested that the woman drink orange juice or be given glucose to increase her blood sugar level and thereby stimulate FMs. This practice is common, however, research has not proven it to be effective. Some sources suggest that FMs increase when maternal glucose levels are low. Other methods that have been used in effort to stimulate fetal activity, such as manipulating the woman's abdomen or using a transvaginal light, are not very effective either. Only vibroacoustic stimulation has had some impact. Interpretation. Generally accepted criteria for reactive tracing are as follows. 2 or more accelerations of 15 beats per minute lasting for 15 seconds over a 20-minute period. Normal baseline rate. Moderate variability. If the test does not meet the criteria after 40 minutes, it is considered non-reactive, in which case further assessments are needed with a CST or BPP. The current recommendation is that the NST be performed twice weekly after 28 weeks of gestation with patients who have diabetes or at risk for fetal death. Vibroacoustic stimulation. Vibroacoustic stimulation, also called fetal acoustic stimulation test, is another method of testing antepartum fetal heart rate. Response and is sometimes used in conjunction with NST. The test takes approximately 15 minutes to complete, and with the fetus monitored for 5 to 10 minutes before stimulation to obtain a baseline fetal heart rate. If the fetal baseline pattern is non-reactive, the sound source, usually a laryngeal stimulator, is then activated for 3 seconds on the maternal abdomen over the fetal head. Monitoring continues for another 5 minutes, after which the monitor tracing is assessed. A test is considered reactive if there is an immediate and sustained increase in variability in heart rate acceleration. The test may be repeated at 1-minute intervals up to 3 times when there is no response. Further evaluation is needed with BPP or CST if the pattern is still non-reactive. Contraction stress tests. The CST was one of the first electronic methods to be developed for assessment of fetal well-being. It was devised as a graded stress test of the fetus. Its purpose was to identify the jeopardized fetus that was stable at rest but showed evidence of compromise after stress. Uterine contractions decrease uterine blood flow and placental perfusion. If this decrease is sufficient to produce hypoxia in the fetus, a deceleration in FHR results. However, at the peak of the contraction and persisting after its conclusion are late deceleration. Nursing alert. In a healthy fetal placental unit, uterine contractions usually do not produce late decelerations. When there is underlying uteroplacental insufficiency, contractions produce late decelerations. The CST provides a warning of fetal compromise earlier than the NST and with fewer false positive tests. In addition to contraindications described earlier, the CST is more time-consuming and expensive than an NST. It also is an invasive procedure of exogenous oxytocin stimulation. It is also an invasive procedure if exogenous oxytocin stimulation is required. The procedure. The woman is placed in semi-Fowler position or sits in a reclining chair with a slight lateral tilt to optimize uterine perfusion and avoid supine hypotension. She is monitored electronically with a fetal ultrasound transducer and uterine tocodynamometer. The tracing is observed for 10 to 20 minutes for baseline rate, long-term variability, and the possible occurrence of spontaneous contractions. Two methods of the CST are the nipple-stimulating contraction test and the oxytocin-stimulating contraction test. Nipple-stimulating contraction test. Several methods of nipple stimulation have been described. In one approach, the woman applies warm, moist washcloths to both breasts for several minutes. She is then asked to massage one nipple for 10 minutes. Massaging the nipples causes a release of oxytocin from the posterior pituitary. An alternative approach is for her to massage the nipple for 2 minutes, rest 5 minutes, and repeat the cycles of massage and rest as necessary to achieve adequate uterine activity. When adequate contractions of hyperstimulation occurs, stimulation should be stopped. Oxytocin-stimulated contraction test. Exogenous oxytocin can also be used to stimulate uterine contractions. An intravenous IV infusion is begun with a scalp needle. The oxytocin is diluted in an IV solution, usually 10 units in 1,000 milliliters of fluid, and infused through a piggyback port into the tubing of the main IV device. An infusion pump usually is begun at 0.5 milliunits per minute and increased by 0.5 milliunits a minute at 15 to 30 minute intervals until 3 uterine contractions of good quality are observed within a 10-minute period. A rate of 10 milliunits per minute is usually adequate to elicit uterine contractions. Interpretation. If no late decelerations are observed with the contractions, the findings are considered to be negative. Repetitive late decelerations render the test results positive. After interpretation of the FHR pattern, the oxytocin infusion is discontinued and the maintenance IV solution is infused until the uterine activity has returned to the pre-stimulation level. If the CST is negative, the IV device is removed. If the fetal monitor is disconnected. If the CST is positive, continued monitoring and further evaluation of fetal well-being are indicated. All right, and that was all of prenatal screening, 190 through 198 and 203 to 206.